All right. Good morning. So happy to see you all here. It's wonderful to see so many of you here with us in person today and also joining virtually from all over the world. Thank you for making the time to be part of this convening. At the WashU School of Public Health, our 6 research networks are dynamic research hubs that serve as the real engine of the school. They bring people together across disciplines, sectors, and geographies to tackle the most urgent public health challenges of our time. Today's event is especially meaningful because it marks the inaugural convening of DISIRN, and it is also our 3rd research networking convening overall, an exciting momentum as we continue, an exciting milestone as we continue building momentum. We are also thrilled today by the scale and reach of our gathering. We're welcoming over 900 attendees, joining both in person and virtually. Participants represent more than 25 countries across North America, South America, Europe, Africa, Asia, and Australia, as well as more than 20 states. With that, it's my pleasure to turn things over to our Dean, Dean Sandro Galea, to open our program.
Good morning. Good morning. Thank you, Courtney. Welcome, everybody, and welcome to Public Health in the Era of Disinformation. So thank you for being here, whether you have traveled to join us or are part of our WashU community. Before I begin, I want to express my thank you to the intellectual architects of today's event, Professors Ross Brownson, Elvin Gang, and Byron Powell, from whom you will be hearing shortly. I want to thank the research network team, particularly Ashley Strum, our network manager, Dr. Morven McLean, our executive director of networks and innovation, the dean's office, and our communications team, who make events like this happen. Thank you for everything you're doing. So as you heard a little bit from Courtney today, our gathering reflects something essential about the moment we are in. As a field and as an institution, I want to take a moment to frame from my perspective why this gathering is apposite. So we are living through what I think can be fairly called an epidemic of misinformation. We all hear about false claims about vaccine, distorted narratives about disease outbreaks, conspiracy theories about public health interventions. And perhaps most alarmingly, these are not fringe phenomena. They are not merely an annoyance. They are actually shaping health behaviors, eroding institutional trust, and costing lives right now in ways we are only beginning to fully reckon with. The COVID pandemic that we all lived through showed us this with devastating clarity. We watched in real time as misinformation spread faster than the virus itself, undermining vaccination campaigns, fueling resistance to evidence-based measures, and deepening the fault lines of health inequity. 3 years, millions of lives lost, and the rending of the social fabric that we are still reckoning with. But of course, COVID did not create this problem. COVID revealed the depth of a challenge that had been building for years, one that extends well beyond any single disease, any single platform, or any single political movement. Over the past decade, we have seen disinformation undermine polio eradication campaigns, fuel measles outbreaks in communities with high vaccine hesitancy, distort public understanding of reproductive health, of mental health, of climate and environmental health. It is a pattern that is accelerating. So that leads me to think that the question before us now is no longer whether disinformation is a threat to public health, but do we continue producing evidence and hope that it finds its way to the people who need it? Do we continue debunking falsehoods one at a time, always playing defense? Or do we build the systems, the strategies, and the science of implementation that ensure that truth reaches communities before falsehood takes root? And I actually think that's what brings us together today. The Washington University School of Public Health is WashU's first new school in a century. For those who have not been part of our community from the beginning, you might think this is a difficult time to be building a school of public health. It is in some ways, but I would argue it's the best time ever, because the challenges facing the health of populations have never been greater, and because the traditional approaches to addressing them are no longer sufficient. There is plenty of reason to realize that we need new frameworks, new methods, new collaborations, and frankly, new ambition about what public health can do. Our school's vision, as articulated in what we call our 4x4 plan, includes 4 directions that guide us forward: new ways of thinking, new ways of working, new pathways to impact, and new partnership. And I think all of these are reflected in today's convening. We have, for a long time now, treated disinformation as primarily a communications problem, something to be countered with better messaging or faster fact-checking. Our approach challenges that paradigm. We are trying to insist that disinformation is a structural determinant of health, one that operates through social networks, algorithmic amplification, commercial incentives, and political polarization, and that addressing it requires the same rigor we bring to any population-level health threat. Today's convening brings together researchers and practitioners from across Washington University and beyond, from implementation science, from communication research, from behavioral science, data science, technology, from community practice, all to the end of understanding how we move evidence-based health information into communities at scale, which is, at its core, what implementation science is all about. Now, this is difficult work. It requires understanding not just what is true, but how truth travels, and why it so often loses the race to falsehood. It requires building the implementation infrastructure, the trusted messengers, the delivery systems, and the community partnerships that ensure evidence reaches people where they are. And it requires convincing funders and policymakers that this infrastructure, although less visible than crisis response, is ultimately more effective and more cost-efficient. Central to our school's vision are our research networks, dynamic research hubs that bring together faculty across disciplines to tackle pressing public health problems. We have 6 of these networks, and we see them as being at the heart of the school, where we do not just study health, but actively work to change it. Today's convening, as you heard, emerges from our Dissemination and Implementation Science Innovation Research Network, DISIRN, a network that focuses on research that accelerates the successful adoption and implementation of evidence-based sustainable solutions to public health challenges. Now, that mission, while it's a mission and it's helpful to us, it's also worth pausing on. We have more public health evidence today than any point in human history, and yet the gap between what we know and what we do has never felt wider. Implementation science exists precisely to close that gap, and disinformation is one of the most formidable barriers standing in the way. It undermines trust in the very institutions we depend on to protect population health. And the work we are doing today, and the work we're about to hear today, represents our commitment to rebuilding that trust, to pushing back on misinformation, to building the science, the partnerships, and the capacity we need. As I said earlier, we aim for this not to be an abstract aspiration, but a concrete program of work beginning today. Thank you for joining us. I'm immensely energized by the program ahead of us, by the keynote presentations that will challenge our thinking, by the panel discussions that will surface new questions, and by the conversations in hallways and over lunch that often prove most generative of all. I hope everybody joining us today in person or online leaves with new ideas and renewed conviction that this work matters, because I really think it does, perhaps more than any work we could be doing. With that, I welcome you all again, and I'm going to hand you over to Dr. Byron Powell, Associate Dean for Research and Associate Professor at the Brown School with a secondary appointment in School of Public Health, whose leadership of our research network, alongside Professors Brownson and Gang, has been central to building this initiative, organizing today's convening, and leading us forward intellectually in this area. Dr. Powell, welcome. Thank you.
Good morning, everyone. It's wonderful to see you all. Thank you, Dean Galea, for those remarks, and thank you all for being here. It's tremendous to see new faces, friends, and colleagues, and really appreciate you spending the day with us. As Dean Galea mentioned, I'm Byron Powell. I co-direct DISIRN with Dr. Ross Brownson and Dr. Elvin Gang, along with the fearless leadership of Ashley Sturm. Ashley, are you here? Can you give a wave to everyone? Thank you to Ashley for making this all happen. DISIRN advances a bold mission, a future where evidence powers action and every community benefits from better health and well-being. Building on 2 decades of institutional leadership in D&I science, DISIRN serves as a catalytic network, one that connects, empowers, and amplifies the efforts of researchers, practitioners, and community partners across disciplines and sectors. We're really excited to move this work forward, and over the next few years, we're planning to focus on 3 core priorities. One is building and applying the science of D&I at WashU, and building and applying that science outside of WashU through our training, research, and dissemination efforts. We also hope to better demonstrate the value of D&I science through evidence of return on investment, storytelling, and evaluation, and we're welcoming all of you as true partners in that effort, so excited to extend this broader network with you all. Today's convening marks the inaugural DISIRN event. Together, we'll explore how implementation science, the study of how evidence moves into practice, can strengthen health communication so that accurate, trustworthy information can stand its ground in a crowded information landscape. It's my pleasure to introduce our first keynote today, Dr. Jessica Steier. Dr. Steier is a public health expert specializing in science communication and is deeply committed to providing accurate, unbiased, and methodologically sound information to better the health of communities. She's the founder and CEO of Unbiased Science, a widely followed platform dedicated to translating complex science into everyday language and pushing back against misinformation. Through her podcast and public-facing work, she helps connect people with evidence about the forces that shape our health and lives. And through her close collaboration and thought partnership with Caitlin Jedalina of Your Local Epidemiologist, Jess continues to push the field of public health communication forward, showing how rigorous science can be translated into clear, trustworthy guidance for the public. Her career spans academia and the private sector, where she is focused on data-driven solutions and the importance of rigorous, old-school scientific values in modern public discourse. She is the CEO of Vital Statistics Consulting, which supports health program and policy evaluation using advanced analytics. In 2025, she authored the New York Times guest essay examining how flawed methods fueled the vaccine autism myth. Holding a doctorate of public health with a concentration in health policy management from CUNY Graduate Center, Steier's career has included stints as an assistant professor and research coordinator at Hofstra. She has also held field positions with the Lewin Group, the Nassau County Health Department, and the New York City Department of Health and Mental Hygiene. Steier continues to dedicate herself to public health and the active dissemination of accurate data to subject matter experts and scientific knowledge to the general public. Please join me in welcoming Dr. Steier.
Hi, everyone. Just hoping that you can hear me. Can someone in the chat just let me know? Let's just make sure. Okay, perfect. Thank you. Thank you so much. Well, you know, I was really disappointed that I could not be there with you all in person. But, you know, life has a funny way of, you know, surprising us. And I actually just tested positive for COVID about 30 minutes ago. But as I texted the event coordinators, there was no way I was missing this. And I'm really honored and excited to be here with you today. I am going to turn off my camera now, I guess. And is someone going to advance the slides for me? All right. You can move to the next slide if so. Okay, so jumping right into it. Things that I did not have on my 2026 bingo card. Needing to explain that vaccines are an incredible public health tool. Measles parties probably aren't a good idea. You probably shouldn't take health advice from someone selling you supplements in the very same post. And the scientific process, while imperfect, is the best system we have for understanding the world. Next slide, please. So who am I and what is unbiased science? As was mentioned, I'm actually a public health scientist specializing in evaluation science, so using data to evaluate programs and policies. And then early in 2020, people started connecting the dots and, oh, public health seems relevant to what's going on now and asking me questions. And I started answering those questions on my personal Facebook page. And then I started getting requests from people who I did not know personally. And so I said, you know what, for my family's privacy, let me create this new space. And that was Unbiased Science. That's how Unbiased Science was born. And I always make the joke that I thought it would just be my mom and her friends who were following along. But I'm so proud to say that Unbiased Science has grown. We now reach via social media between 10 to 30 million people per month. And the large majority of those people are not our followers. And I'll talk about that in a little bit, but that's really important because it means we're not just following the folks who are likely to follow a page called Unbiased Science, we're reaching their networks. And Unbiased Science is more than just me. We're a multidisciplinary team. We have clinicians, we have immunologists, you name it. And that really allows us to cover a large variety of topics. And we do so via infographics, which I'll share some examples. You could see some on this slide, via Instagram, Facebook, anywhere that you can connect on social media. We also have a weekly podcast. We do long form content where we really lean into things like storytelling. I'll talk about that more in a moment. Video. And the point is that we're pushing out information in a variety of different modalities to meet people where they are. And I want to kick this off. You can actually move to the next slide, please. I am not an academic. I am a science communicator who's learned by doing. We often say that we're building the plane as we fly it, and I assure you that is the truth. So why I'm really excited to have this conversation is that I think there needs to be a marriage between the science communicator practitioner, those of us who are out in the world doing this on the ground, with academics, with scientists to really figure out, evaluate impact and potentially improve the way that we're doing this. But what I'm hoping to share with you today is some lessons from the field of science communication. And I'll tell you that I've learned a lot over the last 5 or so years of doing science communication. And what I have found is that COVID and the pandemic really changed everything. And the questions that I'm receiving from people who have absolutely no background in science, who are asking for things like double-blind, randomized, placebo-controlled trials, it means that the bar has really been lifted. And I think that the demands on the science communication community have changed. And one message that you'll hear, I think, very clearly throughout this presentation is that public health needs better PR. And I think we're really losing the PR battle. You can move on to the next slide, please. So something I've realized, as I said, doing this the last 5 years, is that there's some themes shared in viral misinformation. So what are the elements that make content go viral? Emotional triggers, especially fear, overly simplistic, absolute statements that make people feel like, you can do this and you will be healthier, avoid this. It's very black and white thinking. Whereas we in the scientific community, we live in the world of gray and nuance, and that's just not as sexy for people. Also, the appeal to parental instincts is huge. The appeal to desire for control, this idea that we have a lot of autonomy over our health. As I mentioned, if we do this or don't do this, we will vastly improve our health. The appeal to nature, which you'll hear me talk about in a moment, is huge. And of course, the secret truth narrative that really feeds into this anti-science sentiment. Next slide, please. So yeah, it's been a busy few years in science communication. I think the last year in particular has been quite active for us. Here are just a few examples of some social media posts that we've done. I won't spend too much time on these, but the first addresses this idea that we've ignored chronic disease. We've ignored autism, and suddenly we're investigating these things, right? Shifting away from infectious disease and now suddenly, as I said, investigating the drivers of chronic disease. And of course, we know that that's not the case. We also do spend a lot of time debunking myths like this horrific idea that getting measles is beneficial and protective against things like cancer. And then, of course, helping people understand that public health is a victim of its own success, and that if fewer people get vaccinated and when vaccination rates drop, history will repeat itself. Next slide, please. So it was alluded to in the introduction just before, and I don't think I need to spend too much time explaining the moment that we're in right now. But the information environment is one in which institutions are weakened. We see an ever-declining trust in science. Social media has really changed the game. Every single time I open up my Instagram, my TikTok, I'm horrified to see misinformation, disinformation. I'll talk more about it in a moment. And certainly the political polarization of public health. But the good news is that people really are hungry for trustworthy information. And I think this presents a real opportunity for those of us to put out good information, although it is very, very challenging. But there are many independent voices, including myself and others, who are stepping up to fill that gap. Next slide, please. So I'm not sure if you've seen this. Actually, these data come from 2024 Edelman Trust Barometer. There was an update in 2025, very, very similar. It asked people to rank, who do you trust to tell you the truth about new innovations and technologies in health and science? And really interesting to me was that folks ranked someone like them, so their peers, at the same level that they trust scientists. So in terms of dispersion of authority, people turn to their peers, or they rank their peers on par with scientists. And I thought this was really interesting, and it has shaped a lot of the way that I communicate with the public. I'll talk about that more in a second, but I found that the more traditional top-down, more paternalistic communication style is really not working with folks. And so I tend to lead from a place of connection over correction, right? I find some common ground with people, whether it be as a mother or a daughter or whatever it might be. I want to find some commonality, build that connection, that trust before I share information with folks. And I'll share some examples in a sec. Next slide, please. So there was this incredible documentary I'm going to share with in a moment. Actually, before I do, I just want to talk about what are we getting wrong in public health? I mean, certainly there's a lot outside of our control, and I don't want to blame public health. But when we talk to people who say that they're skeptical or they mistrust public health, they often talk about the handling of the pandemic, the way we communicated about vaccines and masking and lockdown. And so I want to take a step back and think about what have we done that maybe contributed to that loss of trust? Part of it is, I think, the deficit model, right? We assume that if we just clearly explain science, people are going to comply. But of course, we know that people make decisions based on trust, on identity, on values, and lived experience. And so information alone is not enough. Also, the paternalism that I just mentioned. I think we've often prioritized being right over being effective. Rather than listening first and understanding what people's questions and concerns were, we lectured. We told them what we thought that they wanted to know, right? Instead of listening first and hearing what it is that they wanted to know. And then there's this thing, and this is what I was just alluding to a second ago, this thing called conditional compassion. And I think this is really, really interesting. We've made empathy contingent or conditional on whether someone made the right health choice. And a lot of people noticed. If you can move to the next slide, please. So the documentary that I was referring to was called I Am Still Here, Love. And it was this incredible documentary that followed the families of 3 people who died from COVID. And it introduced me to this concept of disenfranchised grief. And if I was in the room, I would do a poll to know or to understand how many folks heard of this phrase. Actually, I think I can see you all. Can you raise your hands if you've heard of this term, disenfranchised grief? Maybe a couple of hands. So grief that is not openly acknowledged, publicly mourned, or socially supported. And so in public health, we often make grief conditional on that vaccination status. So when a person in this documentary, the families were saying that, when their loved ones died of COVID, the first question was, well, were they vaccinated? Right? And it's as if whether we mourn them depends on whether they made the right choice. I heard something similar from Dr. Craig Spencer. He's a physician scientist at Brown. He recently attended a children's health defense meeting where he met with the families of the children who died from measles. And the family members doubled down on their anti-vaccine sentiment. And the reason was we were embraced by the anti-vax community. All they did was show us love and comfort. But the scientific community, their very first question was, did you vaccinate your child? And if not, why not? And it felt like an attack. So I think that's also very important for us to understand, right? We can't build trust with people whose losses we refuse to honor, whose decisions we judge, even if there is, some reason why we feel so strongly about this. When communities feel judged rather than supported, why would they come to us for guidance in life? Next slide, please. So I won't go into too much detail, but I mentioned how I'm really leaning into storytelling in my science communication, and this has really resonated with folks. So I recently wrote a piece about how I was at a bar with my mom, and we were sharing drinks, and at the next table there were four guys who I overheard saying things like, "Well, the COVID vaccines were rushed, and mRNA was an experiment." And in the story that I wrote, I detailed how a Brooklyn Jew, and you can't see me right now because my camera's off, but my hands are flailing. I talk with my hands, excuse me, and I physically sat on my hands in an attempt to stay quiet and keep out of their conversation. But I couldn't do it. And so I jumped in and we ended up sharing a few beers and we spoke for 15 to 20 minutes. It was very respectful. And I shared information about mRNA technology. And what I realized was that most of their skepticism came from incomplete information, not anti-science ideology. In fact, they had no idea that mRNA technology is not new. It's been around for more than 3 decades. And so at the end of the conversation, three of them came up to me and they shook my hand. And it was a really powerful moment. And it helped me realize that, not all information is going to be conveyed in a textbook or even in social media. It's going to happen in these situations where we're interacting with others around the dinner table, at the bar, interacting with strangers. And it's difficult to do this. And so I think we need to help people understand, how can you navigate these conversations? And I'll share it more in a little bit about how I hope to help train people, including members of the public, on how to navigate those conversations and really build confidence. Transparently, the fourth guy that was sitting at the table, he was a tough nut to crack, and he really distrusted government. He distrusted pharma, and I don't think that well, I know that I didn't change his mind at the end of the conversation, but maybe that's not always the goal. Maybe I planted some seeds. Maybe he'd be less likely to share a post about this horrific COVID vaccine, right? When it appears on his algorithm. So maybe I did make him think. And maybe we're not always having that immediate impact, which can be very gratifying, of course, but I'd like to think that maybe we're planting seeds that we can't always measure. Next slide, please. Another thing I posted about recently was masking. Now, as a public health scientist, I, studied epidemiology. I know all too well about disease transmission, and there is no question that wearing masks reduces risk, right? Reduces risk of disease transmission. But in this piece, I also acknowledge that that's not the only thing that we consider when we make the decision to mask. And I admitted that even knowing that, I don't mask in all situations. I mask in high risk situations, like at the doctor's office. I mask if people ask me to mask, if I'm around a person who is extremely high risk or medically vulnerable. But there are other things that factor in. I have a daughter who has speech issues, and it's very important for her to see my mouth moving when I'm speaking. Candidly, I get acne when I wear masking. I get hot. It's uncomfortable. I do think that it does interfere with some of my social interactions. So for me, there's a calculus, right? And so, as I said, I don't always mask in all situations. Now, I received so much feedback on this piece from three different camps of people. One, skeptics who are very critical of public health and science. They said, wow, this didn't feel authoritarian. It felt practical. Maybe now I'll actually consider masking in certain situations. I also heard from many public health science folks who said, wow, this is so brave. I won't even post photos of myself indoors because of the pushback that I receive from people if I'm not masking. And then I heard from some other folks in public health science who were horrified, who felt that I was being irresponsible by not advocating for universal masking. So I think this is all just very important to consider. And I know as implementation scientists, you understand that there's much more that goes into the calculus than just disease prevention, disease transmission prevention. And it's very important that we acknowledge all of those other factors. Otherwise, people will just tune us out. Next slide, please. So I think just in the interest of time, I'll gloss over this, but some things that these interactions taught me is that connection before correction matters, right? You can't change someone's mind if they don't trust you enough to listen, whether that's a stranger at a bar or someone online or wherever it is that you're communicating with folks. The messenger matters. I know that information lands differently depending on who delivers it, how they deliver it, and whether the audience feels judged or heard. And there's no doubt that one size does not fit all. The bar conversation needed patience and facts. The masking debate needed nuance and humility, and different audiences will require different approaches. Next slide, please. So I don't think I need to tell folks in the room why implementation science matters and why I think it's the future. It's not just, what does the evidence say? Traditionally, we would post and pray, right, about the science, about the evidence. But I think implementation science takes it a step further. How do we get evidence into real world practice? What gets in the way? And it must factor in things like behavioral psychology, the social context in which we live, structural barriers, and certainly the political environment. Next slide, please. So just an example, I often say that traditionally public health might have said, okay, the Hep B dose is safe and effective, or the Hep B birth dose is safe and effective. That's the traditional approach to public health comms, but it's not enough. For starters, I think that people now don't just demand the what, they demand the why. Why are we saying that it's safe and effective? What information do we have? And we also need to consider why a parent in 2026 might hesitate when they hear this. What sources do they trust? What are their algorithms serving up for them? And I say this because I know when I'm with my mother, who's in a very different demographic. I live in Western Massachusetts. She lives in South Florida. When I log into her Facebook, I see a completely different reality than the one that I'm served up, right? So, what is their information ecosystem looking like, and how is that impacting their decision making? Next slide, please. I just got a 5-minute warning, so I'm going to go a little bit faster. We can move on to the next slide, please. I'll just say briefly here that my biggest gripes with science communication, it feels like we're stuck in a time warp. We've really, we often default to that deficit model, but I don't think that is practical or our reality in 2026. And I think we really need to take lessons from other industries and other disciplines. The MAHA movement, for example, their marketing and their PR is absolutely incredible. And if you saw their latest, real food campaign, it was slick, it was effective, the public ate it up. And so they have us beat. And I think that we really need to learn from these other disciplines. Next slide, please. So briefly, I was invited to this debate by Braver Angels. This was last year, middle of last year. And the resolution being debated was, will RFK Jr. or is RFK Jr. Good for the health of the American people? You can guess where I landed on the debate. But it was really interesting when I listened to what other people were saying. Can you please advance to the next slide? So I learned that Americans are desperate for change. The majority of people could not articulate what RFK's actual policies are. They had no clue what it is that he's actually doing. To them, he represents challenging of the status quo. So I thought that that was really interesting. He represented change. You know, something is not working. Americans are not healthy, and these people are doing something. We don't know what it is, but they're doing something. Next slide, please. So I'm sure the folks in the room are aware of theories of behavioral change a lot more than I am. I'll just tell you that in simple terms, I tend to take a listen first approach where I listen, I monitor questions, comments that we're receiving. I try to understand some of the root concerns that are underlying people's questions, what the gaps are. And I do my best to bridge build. I connect first. You know, I'll lead with something as a mom. I understand why this would be scary if you saw this on social media. But here's the science. Here's some information that you might find helpful. Next slide, please. Okay, I alluded to this. I'm going to go fast in the interest of time, but I think that the bar has been raised on science communication, as I said. People don't just want the what, they want the why. And remember, they like information from peers, right? So they like being let into the process. They like having the respect of us not just telling them that so-and-so is safe and effective, right? We're telling them, okay, here's the evidence. Here's how and why we're saying that. And so here are some examples of slides that I've put together that lift the curtain on the scientific process. And I'll tell you that this is incredibly effective. We've heard from many folks who self-identify as science skeptics who feel like we're not just dismissing them as anti-science. They say, wow, you're actually listening to me. You're giving me the courtesy of responding to my question. Next slide, please. Next slide. So just very, very briefly, and I know we have a little time for a Q&A. I might just eat into it just for a couple of minutes, if that's okay. But there are gaps, there are themes in the gaps in science literacy. So certainly a lack of fundamental science knowledge, vulnerability to logical fallacies, overconfidence in scientific knowledge, and certainly a lack of understanding of some basic principles of research design and validity and reliability of study findings. Next slide, please. So oftentimes in our science communication, we try to educate not just if there's a specific myth that's circulating, but to try to help people understand the underlying theme or the underlying logical fallacy so that they might be less vulnerable to it in the future. So for example, we've done a lot on this idea that natural is better than anything that's manufactured, right? So we've tackled things like sugar composition and helping people understand that actually honey, table sugar, cane sugar, and high fructose corn syrup are quite similar when you actually look at their sugar compositions. Same thing for natural versus artificial butter flavoring, for example. Next slide, please. I'm going to try to go real quickly here. Another major theme is this helping people understand that in vitro studies are very different than in vivo studies, and they all have their purpose. But what happens in a lab or in a rat study, for example, is not necessarily going to translate to humans, right? We see this quite a bit when it comes to things like food dyes or ingredients in foods. People will say, "Oh, but we saw that it caused cancer." And I would like to remind them, well, unless you're a rat that's being dumped in a vat of 5 gallons of red dye, number 3, whatever it is, you probably don't need to be all that concerned. And then using playful analogies and examples of things like correlation not equaling causation. So the classic example of ice cream causing shark attacks. Of course, we know that that's not the case. They just both, we tend to eat more ice cream in the summer, and we're also more likely to swim in the ocean and get attacked by a shark. So some of these examples and analogies really help the information stick for folks. Next slide. I promise I'm going to go quickly. Let's see here. What I'll say briefly here is that I'm guilty of saying in the past, your anecdote is not evidence. But what that does is that dismisses people's real life lived experience. And so I've sort of morphed that over time to say, well, anecdotes are data points, right? But they're not evidence in and of themselves. And I've given some examples here that unfortunately I don't have a lot of time to go through, but to try to help bring that concept to life. Next slide, please. Next slide. So just briefly, I'll say that I play around with a lot of different ways of sharing information. And one that I find very powerful is data visualization. So there was this major scare. I don't know if you remember this. I think it was a year and a half ago at this point where Cheerios and oatmeal, throw it out, throw it out. It's riddled with chlormequat, which is a plant growth regulator. And moms everywhere were in a panic and they were throwing out their Cheerios. And we said, hold on a second. When you actually look at how much you need to consume, over 1,600 boxes of Cheerios in a single sitting or over 200 canisters of Quaker Oats, you probably don't need to panic. So this really helps contextualize risk for people. So I can't say enough about the importance of data visualization. Next slide, please. And we've done this with a lot of things. We've done this with vaccines. We did this with Girl Scout cookies. There was a whole concern about pesticides in Girl Scout cookies. I don't know if you all saw that, but we were getting messages from parents saying that their daughters were getting accosted outside of the grocery store. And so again, we used some data visualization. And I love Samoas as much as the next person, but I'm not going to eat 9,000 of them in a single sitting. All right, let me zoom through these next few slides if you can scroll through. Also, a little bit of humanity, a little bit of humor. So when talking about things like the dangers of raw milk, we used a little cheeky phrase, don't raw dog it, right? We've used some puns like, utterly unpasteurized, utterly unsafe. And people appreciate this. It humanizes us a little bit. We're not just a textbook. Next slide, please. Choosing our words carefully matters. I had the opportunity to have Dr. Paul Offit on the podcast, and we were talking about how we might want to rethink our language selection. So when we talk about things like natural immunity, that doesn't communicate to people the harms of natural infection and natural immunity. So maybe we should start calling it something like survivor immunity to help people better understand the risk that comes with natural infection. Next slide. Respond directly to questions. Canned or vague responses do not resonate. I've already talked about this. Next slide, please. Next slide. Next. One of the things I just want to leave you with as I wrap up here, and I've had to remind myself this, but the mother who chooses not to vaccinate her child believes that she's making the right decision for her child, right? She's doing the best with the information that she has. And so effective communication begins by meeting people where they are, not where we think they should be. And this is often easier said than done. I think I'm wrapping up here. We can go to the next slide. Next slide. Science without humanity is just a textbook. And I think that the way that we're going to reach people is if we lead with our human foot first. And as I have said now 100 times, beating a dead horse, leading with humanity and connection versus correction. I think we're coming at the last slide here, and I hope that I've left enough time for Q&A. You can go to the next slide. I'll just end by saying that I think there's an incredible role for the work that you're all doing and for implementation science. I said that we're building the plane as we fly it, but we do need to measure impact. We do need to understand what works for different populations. How can we improve our messaging? And so I'm hoping that we can marry the on the ground work that many of us are doing with scientific rigor. So I'd love to work with you all and welcome your feedback and ideas for the ways that we could marry the two. next slide is, I believe, my final slide. I just want to thank you all so much for this opportunity, and hopefully there's a little bit of time for Q&A now.
Dr. Steier, thank you so much for making this work, having COVID. We appreciate you being here so much. We do have time for one, maybe two questions, depending on how lengthy they are. So I think we're going to try to keep these to the room just to kind of streamline things. But if you do have a question, please raise your hand and we'll run you a mic. And if you could just state your name and then your question.
Hi, I'm Enola Proctor. Thank you so much for that presentation, and we wish you all well with the COVID. I was intrigued by your story of walking into the bar and admired your courage in approaching the four men to have a conversation. Could you tell us a little bit more about how that conversation went and that you were able to avoid what you've described as the deficit model, assuming that they just needed information? What kind of connections, et cetera? I'd love to hear more of your story.
That is such a great question. And actually, for folks who are interested, I'm happy to share the link after to the piece that I wrote, and then it did get picked up by Stat News. I'd say, how did I establish the connection? Early on, it was very clear to me, just hearing them speak, that a lot of their distrust was sowed during the pandemic, as I mentioned, the handling of how we communicated around vaccines and masking and shutdowns. And so to find some common ground, I gave them a little bit of, I acknowledged that I didn't think it was a perfect response. But I also told them, or I reminded them of where we were. Like, think back to 2020. It's so easy now in hindsight to be critical of the public response or the public health response. But in reality, there was a novel virus that was killing millions of people. I was talking to them. I mentioned to them that my husband's an ER doctor, that many of my friends are clinicians. And I talked to them. I described to them. I said, do you know that my husband lived separate from us during the, during the height of the pandemic? He was scared to infect us, that we were writing our wills. We were planning for death. We were, heard from our friends in New York City that there were makeshift morgues and refrigerated trucks. I tried to remind them of the moment that we were in. So I met them by acknowledging, no, it was not imperfect, but I talked to them a little bit about that moment and how we were focused on reducing disease transmission, right? Especially before the availability of the vaccine. So a lot of that they found interesting. I guess, I don't know. There's an interesting thing going on. I don't know if you've all seen it, where I don't know if it's sort of a psychological defense mechanism, but I think many of us forget what that moment was actually like. So there was that. Also, cluing them in to the science of mRNA vaccines. And I did not, I'm not a biomedical person, so I can't speak to the details of it. But what I shared with them was that it was not new. And I talked about how it's actually been studied for decades, and it was deemed safe in the trials that were running. But unfortunately, for the other vaccines that we were trying to test, they were not effective against the diseases that they were being tested for, right? But we got so unbelievably lucky with COVID. So we were talking about that, and they just kept commenting, wow, I had no idea. No one's ever told me this. Similarly, I'm sorry, I will move on to the next question, but I did focus groups. This is a completely unrelated thing that I was doing with Black Americans who were hesitant to get flu vaccines. And their primary reason for the vaccine hesitancy, a lot of very real and earned distrust of the public health establishment. They were talking about things like Tuskegee. But then they were talking a lot about ingredients. And when I started talking to them about and this was just in a focus group, about vaccine ingredients, a couple of them were crying, and they said, no one has ever taken the time to tell us these things. And 100% of the people who were in those focus groups with me, they changed their mind to get the vaccine. And so I don't know if I'm answering your question. There's so much I want to say in so much limited time. But I think a lot of it is in those focus groups, sorry, I acknowledged, I understand. I can't personally understand, but I can only imagine how concerned you are about these, ingredients in these things based on past atrocities. And they felt seen, they felt heard, and then they felt respected. They felt like, wow, here's a scientist who's actually sitting down to give me information and answer my question and not just tell me to get the vaccine. I hope that answers your question.
Thank you so much. And unfortunately, we only have time for one question. We're going to try to keep the trains running on time. But thank you so much, Dr. Steier. The debate on ESPN this week was greatest athletic performances under sickness and injury. And Michael Jordan's flu game and other things were debated. But we're going to add your COVID performance here. So much.
Thank you. Thank you, guys.
And it's now my pleasure to introduce Dr. Ross Brownson, who's co-director of DISIRN, and the Stephen H. and Susan U. Lipstein Distinguished Professor here at WashU, who's going to moderate our next panel. Thank you so much.
So good morning, everyone. Glad you're here. Hello to all the, I don't know how many, 800 people online. Thanks for joining us. Hope you're enjoying what we have so far, and I see we've got even the cheap seats up above. So I'm Ross Brownson. I'm glad to be here. Thought that was a phenomenal discussion from Jess Steier. We could have had her all here all day and had a long discussion, maybe another time. I'm delighted now to have a panel with us who are going to build on a number of the things that Jess talked about, but also maybe take this in a few other directions. And also for the people online, if you have questions along the way, we'll have some time for questions for the panel at the end of a few of the questions that we've already talked about covering. So with us here, from closest to me is Tyrell Manning, the HIV and STI Prevention Program Manager at the City of St. Louis. And Tyrell is going to, he's on the ground, some ground truthing about doing this in the community here in the local community. Next is Mara Kepper, who is a faculty member here at the WashU School of Public Health. Mara does a lot of different kinds of work, but in this case, it's her work in implementation science and her work connecting between public health and clinical settings and the tool of user-centered design. And then on the left-hand side, right-hand side for you is Spring Schmidt, who used to be in public health practice and now is the CEO and president of the Missouri Public Health Institute. And I don't know if this is the formal mission, but I think the way I think of the Institute, it's a combination of advocacy, capacity building for public health practice, and really just trying to keep the mark for the importance of public health practice in Missouri. And Spring has done a tremendous job with her team bringing this up. So I wanted to start, given we just heard from Jess, and maybe we'll start with you, Mara, is a couple of the threads, things that resonated with you from Jess's talk and things we might build on in the panel discussion.
Okay, well, thanks for letting me go first. Good to see everybody today. So I think the thing that really resonated with me from Jess's talk is that misinformation is not an individual problem, but more of a systemic or systems level problem. So I heard from her that it's really not just about the message. We can't really rely on that deficit model of a clear message, but we really have to rely on the system. So we have to stop framing this as an individual problem or showing it on the fact that they're not knowledgeable enough, or maybe they made a bad health decision. But we really need to start building the systems that allow us to meet people where they are. So I heard Jess say the reason she's been so successful is she's met people where they are on social media. And she even was creating posts about study designs to educate people in a useful way about how we are generating science. So she was really, really trying to meet people where they are. And in my work, Ross mentioned, I focus a lot in clinical settings. And we've seen that trust isn't built right when the message is delivered. It's actually way before that. So we can really erode or we can build trust way before we're delivering a message. So I think that, to me, is really more about the system. And I heard from her that people really need to be seen. So they need to have the information that's being delivered reflect their reality. And I think that's true in healthcare, but also as she was generating messages here to the public. And so we really can't just focus on an accurate or clear message, but really connecting and having humility and tailoring our messages to the context of those individuals. So that's what resonated with me.
Thank you. And we have system science experts in the audience who will resonate with what you just said. Tyrell, what were your reactions to Jess's talk?
I took my notes on my phone. So I think for me, first of all, it was an amazing presentation, honestly. And so I think just understanding, number one, that people are actually hungry for trustworthy information. I think it's very easy to fall into the dark hole of like what's been said and all the misinformation and just get stuck there. But understand that people actually want to know the truth. Like we want to know and unpack like what is actually happening and how it impacts our lives. Connection over correction. I think for me, working in HIV, we tell, in this world, we're telling people how to have sex. We're telling people what to do in their bedrooms, but actually connecting with people to understand and know what they actually feel about what's happening in their lives. And how do we approach that? How do we meet them where we are and help them put action to that in the world of like misinformation? Always listening first. I think it's very simple, but listening. And then, hold on, I was taking a lot of random notes. So, and then understanding the root and then building that bridge. And I think that bridge building is a lot of like what's often not done. I think we want to listen for like data collection purposes, and we want to listen so that someone can write a paper, but like how are we then taking that and actually building a bridge with the community to say, hey, we actually wrote this paper and did this work to actually create action in the community, actually like put this to work and help you understand what's happening and what's the data and what's the science behind this. And so I just think like really the presentation for me was just really about just turning towards community and like allowing them to get information and hear information from us because we've listened to them and not because we're just coming in to tell you what to do because, we're part of this amazing public health school, right? You have all of this knowledge, but people sometimes, like you said in the presentation, they feel very justified in knowing like, I don't want to wear a mask. I don't want to get my child vaccinated. I'm going to stand on that. And so instead of trying to like argue and fight, how do we meet people where they are and actually have communication and community with them and build a bridge that could ultimately maybe lead to more understanding than more infighting and stress?
I think that last point's super important. I'm guilty of this myself. Sometimes we listen to people, but we're also just listening for our little entry point where we can get our point across. And I think that what you're pointing out is true listening and then building on that, not build on something we were already ready to say before we started the conversation. So super important. Spring, what were your reactions?
There were a couple of thoughts that I had. Totally agreed with how great the presentation was and how necessary some of that conversation is. But I've been thinking a little bit about how it also applies to public health, sort of like larger as a system. I think sometimes that the more we abstract to the idea of changing systems or the frameworks, and we're abstracting to the science, we are sometimes forgetting that it's very people-based within public health. Like we have to also understand that systems are delivered by people in context, and even the people who are delivering public health don't always agree with everything that they have read or everything that they have heard. They are receiving nuanced communication as well. These are people in structures in community, and that's who is also messengers like within this space. And it's not universal, it's not monolithic in terms of what they know, what they understand, how they are interpreting what they know and how they are trying to even interpret the things that we know as scientific, or we see as evidence, or we see as systemic answers to these, that they are being interpreted through messengers in context, in community. And like, how are we using the implementation science to build systems that are based on people delivering in context and community? And that part really resonates with me as we think about it. We have to be careful about the abstract when some of what we're fighting, or some of what we're fighting for, is deeply personal and interpersonal and relationship oriented. And if we try to abstract it too much, we're going to lose our opportunities for that connectivity. So that part really resonated with me. I think there's another point that I thought about, some of the things that she said relative to the critique from our allies. And I have felt a lot of that, especially during COVID. Got a lot of pushback about that. And it has really led me to wonder sometimes whether we think about the adage about perfection being the enemy of good, and how we often study our failures and we publish our failures, and and it's important to do that because it's an honest acknowledgement of the things that we get wrong. But we also sometimes apply the deficit model to our own system over and over and over again. We don't expect people to be able to deliver sometimes in those. And we study what's wrong with all of the things in the system. We have been amplifying the deficits in the public health system as part of our delivery of science without giving equal attention to what we do particularly well, to what is in fact working in that delivery. It's so much easier to get a lot of attention. Dr. Gang and I were talking about something last night about so much easier to get attention for all the failures that have happened versus there's real science about some very successful strategies that happened during COVID that were incredibly effective, that have not had near the amplification of. So we have a deficit model view of our own public health delivery system, and we author it over and over again.
Super. Yeah, and I think that point about people and the connection of people in their organizations, in some of our training and implementation sites, we'll talk about how people shape organizations, but organizations also shape people. And those are often the places where others, the public, is getting their messaging about a certain issue. So I think that's great. Okay, so Spring, I'm going to stay with you for a minute here. So you had a lot of experience as a local health official during COVID, and you've had a lot of time to work on and think about this issue of trust and credibility in public health, which is an important issue for implementation science as well. What could you talk about there, about your experience or some of the actual data that would help us think about these issues and how we more effectively convey our messages about evidence-based approaches?
Sure. One of the things that we did at the Institute last year was we did a trust poll for Missouri residents. And we oversampled in rural spaces. We've been hearing from national literature about the gaps in trust in public health, particularly in governmental or local public health. Some of the national data was really dismal. We found nearly the opposite in Missouri. So we did a representative sampling poll for all Missourians. We found a higher trust level in their local public health agencies than their state agency, 12 points higher than the CDC. We found the local public health departments were more trusted than every other governmental entity in their community except for firefighters, who were cooler, I guess. So 60% of the general population trusted their local public health department, which is lower than I would like it to be, but better than I feared. But for those who had received a service from their local public health department, the trust was 74%. So it was higher when they had actually received a service from their health department. They said that 86% of them found their local health department to give the most unbiased and accurate information that they had available to them. So it really resonated with Dr. Steier's mention of someone like me could also be trusted community messengers within that space. They felt their health departments, 89% of them felt, were particularly transparent about what they knew and how they interacted with the public. So when I think about how that impacts what it is we're trying to do as a system in the implementation, it is that someone like me, there is a system in place and people do have a sense of responsiveness that is very personal and hyper-local, and how to reach important messages to that audience so that they can utilize that trust and develop it further to increase the opportunities to deliver high quality information in those moments.
So some surprising good news in there for you.
Actually, it was really surprising. It was based on a poll that I had seen in Nebraska, where their trust in their local health departments was 67%, and so it was much higher than what we've been seeing in some of the national trends.
Super, super. So Tyrell, I think we can build on that question, and you have a long history now working in the community, including working through COVID, and sort of threading on the trust issue, but also just thinking about how public health officials can make better connections with the people they're serving. What were your thoughts about that?
So I think for me, the first thing that comes to my mind is actually, I got a lot of random opportunities that had nothing to do with the job I was actually working at. But like, I think that's the beauty of the work. I got asked to help and support. At that time, it was Alive and Well. And they were simply doing like Zoom calls with community to talk about what, masking, all the protective pieces, how to 6 feet, what does that look like? Why is that important? But outside of like giving out all of this information, it started with listening. Tell us what you're unhappy about. What are you concerned about? What's stressing you out? And so, and having like over 300 people from community on Zoom calls, and we're navigating them into rooms and things, that was like beautiful work that showed me that like we have to listen, like, and again, it just feels so simple, but like bringing people and sometimes just simply listening to like, what's the issue? What is like sitting top of mind for you? And then we're able to move into, in those moments, hey, not only are we going to talk to you, listen to you, provide you with actual like scientific health information, we're also going to meet you on the ground. We're giving out self-care packages. We're giving out masks during that time, going the doors. We're hanging posters, putting things up in community to remind them of the importance. And so that type of work for me, even though it was outside of like what I get to do every day for like work, was like really kind of broadened my own understanding of the importance of like connecting with people where they are. Because again, I come from like sexual health work where we are telling people what to do. And like, it just reminded me to go back and say, no, I have to start with listening to people and then putting that action. And then outside of that, once we get done checking in with them, how are you doing? Do you need any more masks? Like just the connection piece is so important. And so I think for me, just working through COVID, especially with like all the misinformation, I think we talked about on our call, moving through that, we get to like mpox. And, we're having to now deal with mpox on top of COVID. And so we're having literal like vaccination clinics that we're merging mpox vaccinations with COVID vaccinations while you're here, you might as well get tested for your sexual health as well, and allowing community to come in. And I believe our health department hosted one of the largest clinics at that time with mpox and STIs. And we got all of these people connected. And while they were there, giving them other resources, other things to connect to. I think even on the COVID calls, we had mental health support for people that needed it. And so just creating spaces where they're accessing everything that public health has to offer. And I feel like that's been like a theme lastly, because I think as a volunteer, before I even started like official job in public health, I built a program trying to get more Black men who sleep with men to take PrEP. And it was about, again, meeting them where they are. Let's host a brunch, have a conversation, talk about your sexual wellness. And while you're there, Dr. Rupa Patel's team, she's no longer here, is, she's there with getting you connected to PrEP in that moment. You don't have to leave because everything you need is here and you're getting that information. And above all, someone's listening to you and taking that information in. And so I think that has just been the heart of the work that I do and the work that I get to do. And then I have an amazing team that does it. I've been a part of programs and projects, research, spaces within the time that I've done this work that is always centered, starting with listening to the people, and then we put action to that.
Well, thank you. And I want to just say thank you to both you and Spring when you were in the COVID time. I mean, the countless hours you spent on this. I wonder in the thread between this conversation, if there are any lessons we learned about the city and the county and St. Louis working together in public health. And I know that's a long conversation, but any threads there that we might have learned from that we could take going forward about this need for the cooperation between the city county, where we've got this kind of unique government where the city and county are separate public health systems, but connected.
I would say don't let the hype fool you. Like we worked together a lot. Like there were other sort of pieces that were subtle differences between like different things, but we talked to each other every morning. Our staff talked to each other. Like there's a significant amount of like day-to-day coordination, I think, that takes place. There's differences. And a lot of it sort of plays out in sort of a different media space, but the practical hands-on sort of day-to-day work is as coordinated as like I think they physically can be without sort of a constant co-location. Oh yeah. I think it's incredibly important for that like day-to-day communication and work to happen, because the lines that exist for like political jurisdictions and boundaries do not exist for disease. They don't exist for a significant number of people. They don't. It really doesn't, only matters, I think, in a certain context and doesn't in most of the day-to-day practical work.
Yeah. Agree, Tyrell? Yeah.
I think Spring said it. I think I've always, I think, working for the health department, and people say like, when are y'all work together? I'm like, we do. Like I think our EPIs, only because I'm looking at one of our EPIs, our EPIs are always working with our county. We have partnerships. There were like large scale meetings that we've had, where our health departments are working together, because though we're two different entities, like the work has to get done like together. I think I have this weird space where like in HIV, like we're considered the lead agency for the region, but like that doesn't happen without partnerships, and that partnership is with the county and other agencies that are working to like end HIV. And so I think kind of, that might be some misinformation and that goes out, but I think there is a world where, could sometimes it be better? Yeah, but I think largely our health departments work together beautifully.
Mara, this is for you, sort of bridging between what we've heard from Spring and Tyrell, and you have a lot of experience working this intersection between public health practice, primary care, and implementation science. What are some of the things you've learned about partnering and some of the lessons you learned about this intersection?
Yeah, this is a tough question. Thank you. I'm going to build off a lot of what Tyrell, you were talking about, which is listening. And, we as researchers know we need to come into the partnership early and build the partnership early, but we're still generally coming with already a formed question. We have a research question already. We have a funded timeline. We have probably a narrow definition of success. We've named the outcome we're looking for in our grant, for example. But how can we really slow down and listen in the beginning to define the problem with our partners, but also really understand what do they need, what do they think is success, and understand the constraints they have, and really work within maybe the trade-offs that they can make so that it's realistic. And I think I heard you say you work on about 5 diseases at once, which for me as a researcher is quite dizzying, right? And so how do we work together to figure out how we can both make some trade-offs to you get to achieve what you're trying to do, and I can also support you and do some research. So, and then the other thing I would say is that we have to shift our thinking, and I think we are shifting our thinking, and really value practice-based knowledge as evidence, right? So you all are implementing every day. So clinicians and public health practitioners and primary care are implementing every day. They're just not doing it necessarily maybe with the language that I would bring, or maybe even the resources that we bring. And so how do we really start valuing the practice-based knowledge and leveraging that?
Great.
Thank you for that.
Yeah, and I think, actually, I'll return to something you said, Tyrell. I think it was this idea of random opportunities. I think sometimes researchers aren't so great capitalizing on random opportunities because we try to minimize the randomness and make it so prescriptive so the study section will award us a grant, and then we have to implement it, and then the public health world has changed, and we need to be flexible to that. So I think that's a great phrase. I'm going to steal that phrase. So let me come back, and maybe we'll do some quick hits through a few more questions, and then we'll open it up for some questions. Spring, you alluded to the challenges. You mentioned some of the rural communities and some of the political divides we faced. What are we learning about how to better bridge those political divides, and how might that inform our work in implementation science?
I think there's certainly, we can always go back to starting with listening, in that I think sometimes we've been more graceful to other cultures than we have of people with different political opinions. And that is harder, I think, to face when you're in some of those conversations. So I think it's really important to listen. It's really important to find and meet people where they are, regardless of like the differences that you're talking about. Like it doesn't matter whether it's a political difference or an ideological difference or a religious difference or a geographic difference or like a knowledge difference. They're differences. And I think there are things we know from implementation science about stuff that works relative to listening, to doing community engagement, to meeting people where they are and sort of finding common ground. And I think that's necessary. But I do think there's another aspect to this that I have thought a lot about as a former government official, is that governmental public health is fundamentally different. And I think there is a trap in thinking that it's neutral. And I think we have liked in the past to consider public health to be neutral politically or apolitical, but the fundamental mechanism for the delivery of public health services in America is governmental, and by its very nature cannot be apolitical. It can be apartisan, but it can't be, it's a political system. It is the delivery of services by governments that are run by elected leaders. It fundamentally matters that we actively participate in that system with our knowledge, with our experience, with our connections to community, with our opportunities to build power to make change fundamentally different in a system that is political. And so I think we've missed sometimes the idea, and I've met a lot of public health professionals who think that we should be silent, that public health should be entirely in the background, and that its successes need to be, as quiet as possible, and to be apolitical, like in as many ways as possible. And I think that that's a very difficult way to operate. In a system that has at its heart, like a government.
The famous kingdom model of policy change is the problem in the policy and the politics, and I think public health doesn't do the politics real well sometimes. And I think exactly what you said, the idea of being political but not partisan, is something we sometimes forget about.
I agree.
So Tyrell, you built a whole career around a lot of these issues. What about that political divide issue, especially working in rural and urban communities, and the differences and some of the similarities that might help us think about these issues?
So I think it's interesting because I, again, came into this work as an advocate, and I will remain an advocate. I think public health people need to remind themselves that we are advocates for the public. And so I think for me, my work has always centered that. I think I got an honor as well as working with an organization called We Power, and they did a survey throughout, I think it was like over the summer during the president's first term, where they basically went into rural communities and then urban communities and asked them the exact same questions about their lives. What are you struggling with? Where can we do better? What are your needs? And they were literally not that different. But it has been the duty of our system to put us against each other. And it's always like we are always more alike than we are different, and reminding ourselves of that. My skin might be brown. Their skin might be, I don't like to say white because these are like beautiful shades of peach. Very shades of peach, but I get sick. I had the flu last week. They could have the flu. We hurt, we bleed. We are way more alike in all of our differences. And I think it has been that work of reminding the community and reminding people. And I think I said it earlier, I think working with Dr. Ginger, because I got to shout, ClearPath out too. I think coming into a program with Dr. Ginger McKay, and she's been very honest in moments where, hey, I may not get it, I may not understand it, but I'm willing to go back and see how I can get it to work, how we can, because, you know, public health has its needs. It has its boxes that need to get checked, and it always doesn't match what community needs. And so being able to go back and be such an amazing expert and work with people that are willing to say, hey, I can try to get this to bend a little and get, you know, let's see how we can fit it into the narrative. And so I just think it's been very important because, and I'll say lastly, so I saw your card, thank you. I think it has been very hard and exhausting for me, and I had to take 2 weeks off because my work started to become irritating because of where we are right now with like seeing people who I have looked up to as public health people, as the person who like, you have led me through this way, but our government says you can't do this, you can't do this, and they just say, okay, okay, and there's no fight, there's no pushback, yet I'm at the health department, you know, telling people, hey, this is what's in our contract, these are the people that we are meant to reach, we're going to reach them, and I'm not removing it, because that to me is like completely against who I am as a public health person, and above all, an advocate, is that I'm not going to erase people in certain things. And I understand we need funding and stuff, but I think we have to sometimes get that fight back in public health, even if it isn't directly like we're going to go march and protest and push back. You have to use the system to work and to build and to do the work that we do. So that's
awesome. Thank you. That's awesome. Mara, this is kind of the nerdy science part. Think about, you know, one of the methods you use a lot, user-centered design, and how some of the issues we've talked about, how that method might help us address and solve some of the issues we've been talking about.
Yeah, I think that answer is somewhat simple. I think user-centered design gives us a way to ask a simple question of who is this for? What do they really need? And how can they do it? And then we can build a solution that can be designed for them and with them. And so that whole idea of user-centered design is that from the start, we can identify friction points or maybe even leverage points, as I heard you say, right? There's actually a lot of good we can build on before we build something and create a very expensive failure, quite frankly. And so maybe it's about like kind of rethinking, maybe we need to, what we would call prototype, generate like a low yield solution that we test before we move to our perfect thing, which we usually want to do. Maybe we want to test the language before we disseminate it widely. Maybe we need to get better about, or maybe more comfortable with thinking that a usable but maybe good enough solution is okay versus like this gold standard perfect thing that's not useful. And ultimately then is ignored, right? And so that's really how I think of user-centered design. It's a method that helps us do that, and it helps us create something that doesn't just make sense, but really resonates with people. So they've already bought in because they designed it with you, and you build trust with those people by doing this.
Yeah, actually fits really well with the community-based work we're talking about. Okay, so we're going to move to questions, but before we do that, I'm going to give each of you 10 seconds. Start with you, Tyrell. What's something that leaves you hopeful about the future?
I would say that there are conversations like this that are being had, and I feel like I'm just grateful that and hopeful because we are in this moment, and I think it's bringing us to a place where we have to rethink, reframe, and ground ourselves in our purpose and why we do this work.
Perfect. Thank you. Mara.
I would say, I'm going to go back to something Jess said, which is people want to make the right health decision, and we have the tools to help them do that, I think.
I get information every day. People are out there, they're serving. Like they are meeting the public, they are having these conversations, they are delivering services, they are like advocates like in their own way. So every single day there are people delivering exceptional health and public health. And we just have to look at that too, as we're looking at the whole system.
Yeah, good. And I think that theme of every challenge brings many opportunities is something we can all think about as well. Okay, so we have some time. First of all, I want to thank the panel before we do and then we'll thank again. We'll start with some in the room, and then I'm going to take some online. And if you can direct it to a panel member, or you can just put it out there, and we'll let one of them answer.
Hello.
Go ahead. Yeah.
Hello, I'm over here. Thank you so much for taking the time to discuss through this panel about all these insights. We understand that there were issues. I think we all understand that there were issues during how information was conveyed during the COVID-19 pandemic, looking at it retrospectively, because we were really learning a lot of new information about what was really a novel pathogen for humans. And given this, I just have like two questions about this. One, could it have been more feasible not to rely on a deficit model as this was happening, given the information was limited and coming out in the moment? In other words, in a pandemic where people were told to limit social interactions, were in lockdowns, hospitals were overburdened with severe COVID-19 cases, and individual decisions had implications among many of those around them. How should communication have been approached to be more effective and maintain trust in institutions at such a perilous time? And then the other question I have sort of leading off of that is, how do we go about communication in the future, given should there be another pathogen that causes public health crisis that we don't know any information about as we're learning information in the moment? I think I heard from the panel a phrase that we should have the ability to test language before it's widely used, but in these crises, we often don't have that, so.
Okay, so we'll try to kind of mold those together. You want to take a go?
Sure. I've had a lot of nightmare thoughts about all of the things I would say differently. We were never going to outmessage like the ecosphere of information and misinformation. That was never going to happen. We should have localized a lot more of all of our messaging. In terms of like the things that we were delivering sort of in the public, we were never going to outmessage like the internet and all of the other things that were happening sort of within that. We could have outserved and we could have outperformed locally in some deeply like difficult conversations where we said we don't know the answer to things. Where we said, this is what we're doing and what we're trying, and this is why. And it wouldn't have worked in like all of the ways. It could have been better, and it would have been more effective. We were still going to fail in many ways, and we just have to know that. That was inevitable at the scale of COVID-19. But we could have done better. We should have localized a lot more, and not tried to abstract to national things or tried to abstract to easy things like the science says blank. Yeah. We should have said we don't know a lot more, and we should have been more careful and more communicative about the way we were serving.
I'll respond to the testing comment. I think, particularly as researchers, we think testing has to be this big thing. And in fact, with technology, with social media, we can test things quite rapidly and get feedback very quickly on a simple message. And I think that's something, we should have thought about doing, is how is this resonating? What's worrying you about this message? So I just think I want to push you a little bit, because I heard you say maybe we can't test in the speed at which that was occurring, but I think in fact we can.
Okay, now we had, yeah, go ahead. Yeah, please.
Hey, well, thank you for sharing your experience. It's very valuable for me. A little bit of the background of my question is that I have training as a physician, and then I've been practicing public health here in the US. I work in the HIV prevention field, and I found a big disconnection between we have the information, we know what it is, we know that you have to use a condom, PrEP, we know all these things. Why people are not using it? The information is there. People know about this information, but they still don't use it. So I went into a research spiral in science communication. I found health literacy, and I found the Plain Language Act that regulates in the US how public health communication should be delivered. My question is, from your experience, is this regulation use in the moment that you are planning education materials or any type of communication with the public. Because in what I've seen now that I'm aware of this, it's that I don't see it often. And also how to incorporate plain language principles in communication, like with the providers and public health workers, with the patients or clients. Like if you see some type of connection that has been done, not only in written communication, also in verbal communication.
I'll start. I think many people, practitioners that I know, try to use plain language as often as possible. I will also say, though, that I think we're pretty deeply aware that knowledge only drives some of behavior. And so regardless of the language we use to communicate, I think we have to contextualize in the moment all the time, and sometimes that includes plain language and sometimes it doesn't. Sometimes it includes much more colloquial language that is meant to just be very personal between someone. And I think that sometimes that has plain language in it, sometimes it doesn't, because it's much more instinctual and experiential in the moment. But also, like, we just know that knowledge and communication sources, the delivery of information, is only going to drive a portion of behavior. It doesn't drive all of your behaviors.
I would say probably I think one of the things, because I got to work with Dr. Mahdi when she was our director of health, and she was very big on, like, there was no communication that left out of that health department that, number one, was not vetted by her. But before we even got to that communication, we need to make sure we have masks, we have tools, we have the things that we're actually getting into community. Because I think a lot of what happens is, like, I think with Mpox, I'm like, we need to talk to the people, talk to the people, talk to the people. And she's like, whoa, we need to make sure that we have a unified message. There's understanding, it's clear, we're ready to put that out, but before we even get there, do we have vaccines? Do we have the tools? And I think that for me allowed me to kind of understand, Tara, you have to have a clear message, clear communication, and, like, you can't just fly off the hinges, because I probably might be that advocate in me where I just want to, like, save the world. But, like, I think that really kind of grounded me a bit more in understanding, and, like, gave me an appreciation for how we do that in our health department, of, like, making sure that there is a real message that will go out in community that's packaged together with facts, clear communication, and we have the tools to go along with it at the same time.
Yeah, Sydney.
Thank you all so much for your feedback and all this great panel. My question is about fatigue, and Ross, I'm still thinking about the talk that you gave on Convocation over 2 years ago, talking about burnout in public health, and we see this still today, obviously, and I think that with all of the misinformation and trying to navigate that, there's even more fatigue for people in this field. And I'm just wondering how you all are navigating that, because obviously we know, and especially after this talk and Jess's presentation, that it's really important to meet people where they are and empathize with them and try to understand them, but that is harder to do, and it's more work to do than just going in and, like, trying to give them, you know, the information. Like, that can be really draining. So how are you all navigating that fatigue, and how are your organizations trying to navigate that?
That's a great question. So resilience, messaging, mental health challenges, a lot of things roll in. What do you think?
Oh, I quit.
Yeah.
So
That answers that.
So, and I've been brutally honest. I was burnt out. I was exhausted, and I wasn't alone. And I felt like a failure at the point of knowing that I had to go, because knowing that I had to go was fundamentally not about whether or not I thought it was valid. I left a lot of people behind that still did the work, like, every single day. I worried a lot about what that, like, meant for my career, and I had panic attacks before and after leaving my role. I wanted to go while I still loved public health, while I still loved this space, and to find a way to rebuild a voice and a career like within that space. And it's taken some time. I'm a lot more intentional about my self-care, like within the space. I try to make that space available to other people in public health as I'm talking to them. I love governmental public health workers, like every single one of them, and the things that they're doing and the things they're trying. And I turned myself into an advocate for that space, and that feels real. But I can't like sort of deny that I was so burnt out I had to leave a governmental public health role that I knew was impactful, that I loved, in a like department that I loved, with people that I loved, and still had to go. And so I would like that not to be the case for everyone else in that space. But I can't deny that like I left.
I'm just gonna say so, and I know my team is watching. I created a self-care agreement with my team because I have the most beautiful collection of passionate public health people on my team that want to work. And we can't do that all the time. If someone is off, let them be off. If you're working from home, work from home, whatever it is, like take your time, your vacation, your comp time, use it, because I think for me, I got to the point where like, I not only got burnt out this night, I had a heart attack at 31. And so for me, it took a heart attack to tell me, you know what, I'm going to leave this job, not because I don't love them. Literally my first job in public health, love them to this day. But since then, it is me, before I can do anything else for community, I have to center my health, whether it's selfish, whatever. And so taking 2 weeks off just to step away, reminding my team, love you down, love this health department. If anything falls apart in here, I'm not the person that's going to save you from my couch. So, I think just really recentering the center of your work, it should be you and your health and your wellness, because it has been overwhelming for me the last year, and we're still in it. And so do that. But if anything else, I do agree with quitting your job.
Well, Mara, you're not going to be able to quit your job, but any thoughts on that one about the partners you worked with?
No, I was just going to say thank you guys, because I know it's a really tough role you guys are in. I think for me, it's just try to keep the eye on the bigger mission, which I know, and vision, which I know you guys are doing, so that the smaller setbacks can feel like small bumps, although some days they don't.
Yeah. I would say that the encounters I have now with practice, and well as our funders, is just I thank them every time at the beginning of our conversation, because I think unless you're in those trenches doing that work, you have no idea like what you're up against, especially what you two were up against during the COVID time. And I'm glad you took the time to take care of yourselves. There's another question online we're not going to have time to get to because we'll have to head to break, but I think it's one to keep in mind. And I think the next, in Heidi's presentation, the next panel, the question is about how to combat the anti-science, anti-public health. But I feel like we've talked about a lot of those things. It's a process. It's going to take time. It's going to take all of us working together to do that. So let me thank once again the phenomenal panel. And we move to break. We have a 20-minute break. There's some refreshments. You can get up, walk around. We ordered good weather for you today, so enjoy the outdoors as well. So thanks, everyone.
All right. So thanks, everybody, for being here. And I think this has been a really exciting morning so far, and more to come in this session. And I think we're really hitting on some of the most important conversations in public health and in society today. So glad to be here. Our next keynote speaker is Dr. Heidi Miller. Dr. Miller is a physician, a public health leader, and is the Chief Medical Officer at not DHSS, but the Department of Health and Senior Services. We had a acronym reducing primer this morning. So I think Dr. Miller is also a member of the advisory committee to the director of the CDC. And before taking this leadership role, she led clinical care at federally qualified health centers in the St. Louis region for many, many years after completing her training at Harvard and Yale universities. So I think it's always, I think from my perspective, I'm wearing my clinician hat, wonderful to see leaders in health who have hands-on experience and who have their fingers on the pulse of the experience of people. And so I think we're very glad to have you share your wisdom with us today. So I'm going to invite up Dr. Miller, and then after that, we'll have a panel conversation. Yeah.
Can you hear me okay? I'm really honored to be included today. We need your help. I am privileged to try to serve in a capacity as CMO for the state of Missouri, but there is so much information that we need, and there is so much information that we need to spread and to convey. Today I'm going to be pretty frank, gloves off. I'm going to confess the mistakes that we've made. Many of them I have made myself. The title of my talk is Power, Arrogance, and Impotence. And the key thing is the positive part of how do we reconcile our health information blunders. Here is our agenda: power, arrogance, impotence, and finally, the antidote. This is where you come in. First, I have to set a context. Public health endeavors and healthcare must cohere within a broader public health ecosystem. There are false seams in between those entities. Healthcare delivery and public health and health policy are inseparable. I'm trying to operate within a state public health department. I'm trying to interact with lots of different stakeholders, and I still do primary care at my federally qualified health center on Friday afternoons. The work that I do is inseparable. And part of the reason why we have to think about a broader public health ecosystem is because in the state of Missouri, we are ranked 51st in the nation for public health funding by the state per capita. So that's $7 per person per year. We don't live in a country and we don't live in a state where our government public health is going to solve our public health problems. And guess what? Public health is not limited to an epidemiologist doing surveillance. It's maternal child health, it's STIs. There is a need for us to bridge across these like falsely separated fields. I learned this lesson during the pandemic when I pulled into Spring Schmidt's parking lot to get my COVID test. I went to the hospital to get my COVID shot. And as an FQHC primary care doctor, every Monday morning for 4-hour shifts in 99-degree weather or 20-degree weather, I was doing nasopharyngeal COVID tests during the pandemic and wondering, why am I doing this? Where's the public health system? And what I didn't realize then, that I realize now, is that I was part of the public health system. And so we need to establish that broadly. Part of my job has been partnering with external stakeholders and healthcare providers to let them know we can't do this without you. So I think of public health under this broad umbrella, and likewise, public health and healthcare information coexist within a broader public health information ecosystem. That's the context. So when I explain the mistakes that we've made as health leaders, I mean public health, I mean doctors, I mean all the other institutions where we are operating underneath this broader ecosystem or umbrella. Let's start with power.
For so many decades, health leaders have been brokering this power, hogging it, hoarding it, depriving the public of it. Own it. If you're wondering why people aren't listening to us, we did things that made them not want to listen to us. Information is power. Who's brokering this power? Us. And here are the barriers we have built to fortify it, and these are also barriers for us to climb over as dissemination and implementation scientists. Paywalls, obfuscation, time traps, attention theft, gatekeeping, accountability gaps. Let's start with number one. Paywalls, medical articles. The fact that the public pays for much of the research and they can't even review the article. If we wonder why people aren't listening to us, it's because we have not allowed them to, and we have trained them not to. And even when someone is really motivated and like, what? This NBC article quoted this JAMA paper saying this, and it's surprising. Let me look up that JAMA article. No, you only get an abstract. And only the privileged people in this building and the med school and my MPH student who's working with me has access to that library. I don't even have access to that library as a public health official. And I'm supposed to be making decisions. It's too expensive. Copays. You can't get information from your doctor unless you pay money. Sometimes you can't even get a refill. You can't even pay the copay for your refill until you pay the copay to see your doctor. You can't even get your own medical records without spending a lot of money. Now, that's supposed to be different since the American Century Cures Act. However, I still have patients who can only function on paper, not electronics. And I know because of our disparate systems, our disconnected systems, I literally want them to walk into the specialist's office with a packet of paper and give it to the endocrinologist, because I don't trust the system for electronic records to connect. But they have to pay. Not only do they have to pay for the information that you generate, the information that you're trying to implement, they have to pay for their own information. You know, the median cost to access a single paywalled medical article is $32. That's why I pulled out the pay-per-view for the article, pay-per-view for your own records. Tuition is another paywall. Okay, well, if you can't understand it, we'll just spend a whole ton of money and become part of a professional. And then don't even get me started on price transparency. They only gave me 30 minutes. But the lack of price transparency is another brick in the paywall, right? Even if you can afford it, the fact that you don't know if you can afford it. Like the time that I went to see the orthopedist and he referred me for a hand splint and it totally took care of all my problems, and then 6 weeks later I got a $500 bill for the hand splint. You only do that. Now I understand why my patients won't follow up on referrals that I give them. You get burned. Number two, obfuscation. We need to own our faults in order to engage the public and patients. Now, I'm not saying that all of us do this. I own up to every fault that I'm going to present today. The system in which I was trained, the system which I agreed to be trained within, fuels these errors. But we can only make a difference if we understand the mistakes we've made. We have a lot of comprehension blockers. Language, the medical lexicon, our acronyms. Thank you for mentioning that. If we want to exclude people, we will use letters and terms that they don't understand. And it's actually, students, public health students, medical students, and my journey through medical school too, you think it's hard to learn all those new words. I mean, becoming a doctor is like learning a huge new vocabulary. That's not the hard part. The hard part is not using it. You need it technically for problem solving and communication with peers, but how do you stop using it? And then I suspect that there are some of us, and maybe sometimes for me in my immature years as an unseasoned doctor, do some of us in public health and healthcare delivery use big words to intimidate or to secure our sense of authority, when actually what we're doing in public health and primary care and inpatient care and medical care is really hard. There aren't always crystal clear answers. And sometimes we hide behind our white coats and we hide behind our big words. And maybe if we use big enough words that our folks don't understand, they won't keep asking questions that I don't know the answer to. We also use just the symbolism of this is very compelling to me in terms of these language barriers. We use very little letters on little bottles. And it's only a small percentage of providers that actually write on the prescription what that drug is for. I try to remember it, I don't do it 100%, but this one's for your diabetes, this one's for your thyroid. The more you write, the littler the letters get. We can do so much better. Also, our data may be indigestible. I think the most talented people in my Department of Health is our Office of Public Information. Brilliant communication experts taking data, turning it into meaningful infographics, and also tying that into storytelling. We're losing attention to content creators. We will only overcome that if we acknowledge and own that we have been content concealers for a long time, decades, and we need to expunge that habit in order to move forward, instead of just getting frustrated that our patients are listening to this Instagram post instead of listening to me. Number 3, time traps, another barrier where we fortify our power. We make people wait for appointments, wait for your message to be answered, wait on hold on torturous phone trees, wait in our waiting room, wait on the phone. And this was a reminder for myself. Who's not making the public and our patients wait? All of the social media influencers. They're immediately available. They will immediately give you information. They will, there's instant comments. There's no waiting on the phone. We also schedule patients and public health interventions to our convenience. We also shrink people and problems into 15-minute encounters. I hate this. I'm at fault for it. I'm part of a system that does that. I can't fit congestive heart failure and her husband died and new atrial fibrillation and, oh, you need refills on your diabetes meds, and apparently I'm 18 months overdue to do your foot exam in 15 minutes. But we squeeze patients, we also squeeze the providers. So some of this, it's not an individual fault, it's a system's fault. Let's fix the system. Another time thing is that we interrupt. And you know what? As a primary care doctor, I can't survive without interrupting. I can't do anything for the patient without interrupting. The system is designed for me to interrupt, otherwise nothing will happen, and I still run an hour and a half behind, despite wanting to be an on-time person. The fourth way in which we fortify our power is attention theft. Our laptop screen is a vertical shield. And this is a picture of me with a patient, like I am at fault with this. There are systems, ways to improve this. Ambient listening for all providers. We tried to squeeze that into the Rural Health Transformation Program grant for $1 billion for 5 years. Please do this for providers and for patients and for institutions. We gift our gaze to the computer. And guess who's not doing that? Guess who's not? I'm literally in 15 minutes trying to get a history, write my note, because I can't write it afterward, otherwise I will be at the clinic until 9 p.m., literally. So I got to write the note, get the history, and then put in the orders at the same time. But you know what? We are all humans. We are all mammals. We like attunement and eye contact. I do it as much as I can, but I feel torn. Guess who's giving eye contact? The TikTok influencer who is looking straight at their ring light, directing it into the camera. And they will give you all the time in the world because they realize, like, in order to be successful, you need a lot of content. So if you really like their messaging and they were looking right at you, and you're like, okay, this makes sense, that resonates, all you have to do is click a button or to scroll to, like, get the next one, get the next one. So the patients can go to social media and scroll through all this personal attuned advice, and they know that my attention is not scrolling through all this material just for you. It's scrolling through all this list of 24 patients I'm supposed to see today. I know it. It's excruciating to try to meet that demand, and the patient knows it too. We also focus first on what we care about instead of what the patients care about. So in trauma-informed care learning, we learn to not say what's wrong with you, but what happened to you. But what really matters is what matters to you. I experimented with every permutation, talking about COVID vaccines with my patients and thinking about public health implications of that. And what matters to you, that is the connection point, whether it's COVID vaccines or starting a blood thinner for your AFib. What matters to you? What matters to you, not what matters to me. And then gatekeeping. Okay, as a very hardworking FQHC primary care doctor, I take great offense to this term gatekeeping. But we know gatekeeping is like, oh, you got to see your primary before you can go see a specialist or get your MRI. But we're gatekeeping information, not just additional specialty services and diagnostic services. Number 6, accountability gaps. So, all right, we got the information, but we have access to it, but sometimes we don't have all the information. Early in my career, I couldn't tell a patient, I don't know. I do now, we all need to now, and Spring Schmidt noted this as well. When do we say we don't know? When do we say we got it wrong? I don't know, it's not enough, we need to do it more. Only after over 20 years of primary care, as an example, do I have the confidence to say, I don't know. And when I send my patient to a specialist, and they're like, well, I saw the specialist and they said they didn't know, but they were going to look it up and get back to me, I instantly trusted the specialist. Hallelujah. Someone who can say, I don't know. We need to fill those accountability gaps. So quick review. We finished one part of the agenda, power. Public health leaders, doctors, hospitals, health leaders, we have been hoarding it. And the barriers that we use to hoard it are paywalls, obfuscation, time traps, attention theft, gatekeeping, and accountability gaps. Moving on. Number 2, arrogance. There is so much arrogance in decades of assuming that we've been hoarding all this power and we just assumed that the public and the patients would wait. They'd wait for us to share info. They'd wait for patients in public to hang on our words. They'd wait for our sterile waiting rooms, and they'd wait for public health orders. Well, guess what? They stopped waiting. Like a young adult outgrowing their parents' didactic advice. You know what? My young adult sons don't want to listen to me anymore, especially since I talk too slow, apparently, and they can find out the answer online anyway. They have other sources of information. So this old-fashioned, as was noted earlier by Dr. Steier, this like paternalistic perspective, public health and healthcare and parenting are remarkably similar, especially if we're talking about communicating with, connecting, motivating, and fostering the autonomy of those people whom we love that we are trying to take care of. There's also arrogance in assuming that they would obey. I kid you not, I started medical school 100 years ago, and all the old gray-haired professors were like, welcome to the club. You are God's gift to healing. I mean, really, the brainstorming, I assume it's been diluted since then, but this sense that like, you're going to put years and thousands of hours into memorizing facts, and you're going to be able to do brilliant diagnoses, and you're going to know the most evidence-based treatment, and then all you have to do is write the prescription or explain what it is to the patient. And we were all taught through 7 years of training that that's when the work ends. And that's when it begins, because it turns out that human beings aren't robots or pets who obey. And then we use ugly words like, oh, these patients are non-compliant. Like implementing evidence-based cures or interventions requires engagement, respect, granting, acknowledging, loving a person's autonomy so that they can choose to do what you are recommending. There's also arrogance in blaming patients. We have a long, ugly history of blaming patients, blaming the public, and also just assuming like, oh, this is just a political difference. How did health become so political? How did public health become political? I've been in Jefferson City for 3 years interacting with legislators that are bipartisan, and here's my lesson. With very rare exception, everybody, regardless of their political affiliation, cares about health. And there's someone in their life whom they really care about. Talk about the the power of storytelling. They have a family member with alpha-gal syndrome, or they have a constituent. And I have a patient where if you were to judge them by their voting record, you would assume that that politician didn't care about people. And yet behind closed doors, that same politician can tell me that their constituent almost died from an undiagnosed epilepsy disorder. They never had access to a neurologist. They never had their EEG, and they want to make a difference. So they're going to start passing a law called Sophie's Law, because the patient was Sophie, for example. And this law is going to say that doctors have to do an EEG under these circumstances. So, and I'm going to get to this later in the talk, we all care about health. So instead of practicing medicine without a license through legislation, what matters to that legislator? What matters to that patient? It's access to care, early care, affordable care, respectful, approachable care. Because it turns out there are thousands of diseases. And this is a reminder that I bring to our policymakers that yes, this, like the whole disease-focused intervention, or let's have a bill about this one disease, or let's have funding for this one disease. There are thousands of diseases. How can we be holistic with each individual? How can we be holistic with communities? There are so much potential for connection across a political divide in the realm of public health and healthcare. A common language is health economics. We all want the same thing. We all want access to care. We want to be able to access cures, and we want it to be affordable, and we don't want to waste money, and we want a good return on our investment. So communication as a science and art was also not historically, academically an elite priority. And shame on the academic institutions that did not recognize that it does not matter if you're right. It does not matter if you carry the truth. It does not matter if you know the most evidence-based practice or you were the one to prove it. None of it matters if it is not communicated correctly. Number 3, that leads us to impotence. So the consequence of our power hoarding and our arrogance is disinterest, disdain, distrust, discredit, dispossession, disconnection, and we're going to go through one of those at a time. If we hoard all the power and information long enough, at best, no one's going to care anymore about what we have to say. At worst, they feel disdain. If we have hoarded the information so long, we are vilified into this secret-keeping, cure-concealing, private elite that profits from hidden knowledge. And this was touched on in Dr. Steier's presentation this morning. It's incredible how many posts, books, magazines lure someone in with, your doctor didn't tell you. I'm going to tell you what your doctor didn't tell you. I had 100 other examples. It was very hard for me to choose which ones to put on the screen. What doctors won't tell you. 5 secrets your doctor isn't telling you. Dr. Steier, when she had that really powerful slide about what draws someone into a media post, this does. That's distrust. People are pissed off, and they have the right to be. If we've been hoarding all the information, then it's like, F off. Like, it turns out that I can get this information. You've been hiding it from me, and oh my gosh, now I really want to hear what it is because it has not been disclosed to me on purpose. Discredit. You know, in healthcare, we talk about the right care, the right place, the right time, the right person. Good return on investment, good patient care. For health information, we should think about it in the same way. We need the right kind of message, which is not our paternalistic, like, oh, you need to know about this. It's what matters to you. Okay, I'm going to try to answer that. And that's the message that we can convey, but it's really more of a conversation. And it's right here, not like you need to make an appointment at the public health department over, like, I want it right here. Because if we don't provide it right here, they can find it on something on their phone right here. And then that leads us to the right now, and then the right person. So who's the right person? It's our trusted messenger. Our really talented communications team at the Department of Health, I asked them, like, what really makes a difference? We got so few public health dollars. Just yesterday, we presented our budget with governor recommendations. Our Department of Health, remember I told you we're 51st in the nation? This year, our budget is now $50 million cut, 15% cut. We don't have enough money to do what we need to do. So, like, what really works? What really works? And the Office of Public Information said, you know, it may not be billboards or pamphlets, not sure about radio ads, but influencers. What are influencers? They're trusted messengers. Let me give you an example of the trusted messenger. So when I was early in my practice, and this was 20 years ago when we actually still were using OxyContin for pain, I had a 65-year-old lady with debilitating hip arthritis, and it was really bad, bone on bone. She clearly needed hip replacement. And unlike many of my other patients, she actually had health insurance. She had Medicare, she could get her hip replacement, but she just didn't want to. She was apprehensive month after month, and she was asking for pain meds, and it wasn't because she was drug seeking, it wasn't because she was addicted, it was because she was in excruciating pain, and she was just so scared to undergo a major surgery. One day, it took the lady in the YMCA women's locker room. She was in the locker room undressing, and she saw a lady with a linear scar down the side of her leg, and she's like, what's that from? And the lady who was swimming and had been swimming faster and more laps than she had been swimming said, oh, that was my hip replacement. And then she's like, what was that like? And she's like, oh my gosh, incredible. I feel like I'm 50 again. I wish I had done it 10 years ago. She got her hip replacement. And that was good that happened to me early in my career. And I was like, oh, there goes my ego, inflated by those professors. Like, oh, the lady in the locker room, the stranger in the locker room matters more than me. I could get pissed and burnt out about it, and doctors are very good about measuring their burnout, or we could just accept it. Okay, number 5 is dispossession. So we're losing ownership of this knowledge. So now who owns the information? Now who has the power? Like the Himalayan salt diet or detox, or I'm just going to have my phone tell me what to do. If we keep our paywalls up and we hold on to our power, then the media is going to interpret it, the science, for us. And as we think about losing ownership of this knowledge, and this is for the researchers in the room, I think it's really important to delineate between 2 ways that folks collect information: the pull and the push. So the pull is Dr. Google, which is now Dr. ChatGPT, or Gemini. Had a 20-minute conversation with my 20-year-old son who refused to see a doctor because he works in AI and told me that Gemini is incredibly intelligent and there's no way a doctor could know as much as Gemini. Like, oh my gosh. So years ago, we all used to get super irritated that patients would go to Dr. Google. Well, let's try to understand it. Why did they go to Dr. Google? Because Dr. Google doesn't make you wait. It's immediately accessible and good for them. Then also there's this push. So what gets pushed to you when you weren't even seeking an answer? Okay, so disconnection is, of course, the last one. What did we do wrong to get this disconnected? Our efforts were to connect, were really efforts to control. And so reclaiming that connection by resurrecting respect or autonomy is key. We need to repair by reconnecting. Quick review. We talked about impotence, all of these Ds, too many to count. Disinterest, distrust, discredit, disdain, dispossession, disconnection. Lastly, the antidote. Dissemination and implementation scientists, we need you. There are 4 key themes to the antidote. Much of it has been covered so far. The number 1 thing is to readjust our power stance. Let's own it. Like us healthcare folks, and include that in the whole umbrella term of the public health and health ecosystem, own the fact that we have been greedy with our power and we will never reach our audience unless we step off the pedestal. We need to find alignment, not debate. We have to stop repeating our errors. We keep doing this. We've been frustrated for a long time that patients aren't listening to us, they're listening to someone else. And then we need to invest in trust. Let me check time. I don't want to go over on time. Oh yeah, I got to wrap up. Okay, I'm going to save my 2-hour lecture for later. But instead of going into deep detail into these 4 items, a comment on trust. I have participated in such different types of quality improvement and care efforts. And everyone's like trying to come up with like this new innovation, and maybe the answer is technology. And every project that I've done comes down to trust. And trust only comes from continuity and relationships. But we know that, but we keep ignoring it. We do shift work in the hospital. We haven't invested in primary care. Primary care investment in this country is like 4 or 5%. I have patients that won't do the flu shot, but they'll let me take care of their chest pain, and then they'll gain some trust, and then maybe 6 months later or the next year, they'll say yes to the flu shot because I actually helped them with the thing that mattered to them. Trust, relationship, and continuity is key. And that is why, let me fast forward ahead. That's why the poll that Spring Schmidt did indicated that people in Missouri trust their local public health agencies. And I know why. I've met the incredible, understaffed, overworked staff at those local public health agencies, 115 in the state of Missouri. They're incredible, and they care. They care about people. They care about science. And never mind that they are literally, or let me be careful, were literally reading the CDC website and conveying that for their community. Folks didn't trust the CDC, but they trusted the nurse at their local public health agency. They also trust their primary care health home team, and yet we have a dismal investment in that. Oh my gosh, can you implement that? Let's increase public health and primary care. Okay, so to review, these are some of the antidotes. I hope that during the panel, we'll talk about more of them in the context of vaccines. To summarize, power, arrogance, and impotence, we really need to reconcile the mistakes that we made and create actionable things directly in response to that. And this is my last slide. I turn it over to the panel for us to talk about new opportunities, especially in the context of vaccines. Thank you.
Okay. Well, anyway, thank you. That was amazing and provocative and much to chew on, which I hope we get into a little bit here. We have panelists that are going to join us up here, Dr. David Carter and Dr. Mark Huffman. Maybe as you come up, we can take one or two questions from the audience for Dr. Miller. So any takers? Yes, we have a gentleman in the back there. If there may be a microphone en route to you.
Thank you very much for that insightful presentation. My name is Ahmed. My question, I have a few comments and questions. First, I've been thinking about social media influencers and influencing. And I was wondering whether you would think that, say, admission officers, say, in public health schools, should consider being a social media influencer as a big positive during admissions and scholarship decisions, for example, if that would be helpful. Or whether you think that the reason why some people are so good at social media influencing is maybe because they're not constrained by truth. So basically, is truth compatible with social media virality or going viral on social media, for example? And
yeah, if I understand your question correctly, truth is absolutely compatible with social media. Doing it artfully in an evidence-based way, and recording data in real time, like what Dr. Steier is doing, I think is very, very appealing. The other thing is using social media to put the autonomy in the person who's reading it. I'm going to share one thing that happened with our department. We were really burnt out by the COVID and vaccine messaging. And we posted one message that was like, COVID vaccines are available now, and then if you're into that kind of thing. And our department, we had approval from the director at the time. The department received, it was polarizing. The department, some of them were like, thank you for realizing this is a choice and that you're not just lecturing at us that like, this is the truth, this is what you should do, go get it, go obey, go fetch. And others were thinking like, this is outrageous. Like, why would a public health department do this? This is reckless. But I think more and more we need to push the limits to provide truth, but do it in a way that respects the autonomy of the person who's reading the post. Did I answer your question, or I'm happy to talk afterward too?
Thank you. I just have a second part to that, and you already touched on it, and that's about anti-vaxxers, even in healthcare. For example, the Surgeon General in the state of Florida went to Harvard Medical School, and his opinions are often at variance with that of the CDC. But thankfully, somebody like Dr. Emmett Oz recently came out to say people should go get the measles vaccine. what do you think about those?
I should probably debrief afterward to answer that particular question. Let's chat afterward, because what you're asking is about 5 different big, important questions. And it's important that we convey information in a way that empowers our audience and makes them feel relieved. And one example is that the feds recently shifted some vaccines, and this may tie into our panel, vaccines into shared clinical decision-making. It's important to emphasize that nobody has ever given someone a vaccine against their will, but that in fact, it is always a decision as to whether or not to give a vaccine. But I'd love to catch up afterward too for further discussion. Thank you.
I see a hand here, but if it's okay, we're going to launch into the panel, but there will be opportunity for folks in the audience to weigh in with thoughts, and we're looking forward to yours. Just to introduce briefly our additional panel members, and I'm going to ask each of you to react a little bit to Dr. Miller's talk, as well as the other conversations that have gone today. We have Dr. David Carter, who is a political scientist, and I think we're very fortunate to have a diverse set of perspectives, including those from political science, which those of us in health don't always have the opportunity to be in dialogue with. So thank you very much for being here today and sharing your insights from a different area of scholarship. And then we have Dr. Mark Huffman, who is a cardiologist by training and is one of the directors of the Global Health DISIRN, or network. Apologize for the acronym. And has done a lot of work recently looking at the question of trust, and we'll be interested to see what recent insights you've gained in that area. So maybe I'll start with you, Mark, if that's okay. Yeah, maybe you could say a little bit, if you like, about yourself and your background, more than what I've been able to give, and then maybe launch into some key discussion points or questions you have.
Sure, thanks. So I practice preventive cardiology, and I have clinic this afternoon, and I'm going to be talking with my patients about, things that are in the future. And we all do care about health, as you said. I mean, this is something that's universal. Dean Galea has spoken about this. And one of the concepts of trust that's really important to recognize is that there is a degree of vulnerability. Like, why would I need to trust you? If I have no vulnerability, then I could blow you off and it has no bearing. So a lot of the time horizons that we're talking about in public health and in primary care, ambulatory practice, is long-term decision-making. And so that emotional can override the immediacy. But as a cardiologist, I also take care of people who are in the midst of a life-threatening condition like a heart attack. And I can tell you those dynamics are really, really different. In the emergency department, when someone is having an ST elevation myocardial infarction, and I'm saying, I recommend that you get an angiogram so we can evaluate your heart arteries directly and potentially open up what I think is a blockage of one of those arteries. And I distinctly remember one of my patients when I was at Northwestern saying, no, I don't want to do that. And I was just bamboozled, surprised, like nobody ever says no. And I said, tell me why don't you want to do that? He says, I think I'll be okay. And so then I got in and real wide-eyed, and I said, listen, this is serious. I'm concerned about you dying tonight. And I'm not saying this to just get a rise out of you, but this is what most people do. Let's talk about risks, benefits, alternatives. So we had a 3-minute conversation, and he said, yeah. And he kind of shook himself out of it. So we take him up to the cath lab, and on our way up, he goes into ventricular fibrillation arrest, cardiac arrest, and we're ready for it. So dial it up, give him a shock, boom. Take him to the cath lab, open up his artery. And after that, he goes, boy, I'm sure glad I listened to you. And I said, well, thank you for trusting me, because it was a scary moment. And if you didn't make that decision, I think things would have potentially turned out differently. 8 years later, he died in a fatal motorcycle crash. And I took care of his brother for many years. So this idea of trust, I want you to think about the vulnerability aspect of it. And when people are coming to see you in clinic or see you in the hospital or in a public health setting, I mean, there's some vulnerability, that care and tact that I think, Ross Brownson, like you teach me a lot about that, about being polite. It's amazing how many people can be rude, and that is very off-putting. Like, how can I trust you if you're not even polite to me? So, yeah, Dr. Miller, thanks for your comments, and I look forward to more discussion, Alvin.
Maybe your comments and thoughts, please.
Yeah, so I really appreciated your talk, Dr. Miller. It was fascinating. So I come at this from probably what is an unusual angle for the room, in that by training I'm actually an international relations scholar. So most of my research over my career has been on studying the causes and consequences of conflict, territorial disputes, and so on. 3 or 4 years ago, well, actually 4 or 5 years ago, the time kind of blends, the years go by. I got interested in the topic of trust, and it was through my traditional research interests. Find ourselves in the midst of a global pandemic, and realize that there's a vast literature linking trust in political institutions, and just trust in other people that you don't know, social trust, to public health outcomes. And this was obviously very pressing at the time, right in the middle of COVID. And so I got engaged in this project and thinking about how trust affects public health, and how different sources of trust affect public health. And Mark is absolutely right that it's about vulnerability. Trust doesn't matter if you're not making yourself vulnerable to someone. And we all know, if you think about what really matters to people, or what makes people feel vulnerable, when are you actually vulnerable? There are few realms of policy or daily life that have more of a direct impact than health, right? Public health. It's very personal, and it matters to everyone. Everyone cares about it, right? And so, political scientists correlate trust with all kinds of outcomes, right? But few of them involve, do you trust getting these vaccines where they're gonna actually stick something in your arm and inject something into your body, or you're gonna have to allow them to do that to your newborn or your child, right? That's just a different kind of decision than a lot of the things that are affected by trust, right? And I was very struck. So I'll try to wrap it up. I'm a professor, so I tend to I can talk for an hour, right? So I'm not gonna do that. But a lot of the work that I've focused on, that I've done in my research that's ongoing in this area, has looked at, so how long-term, there are these sort of long-term effects on trust, right? So, how does a war that maybe ended 80 years ago continue to have sort of downstream effects on the way people view institutions, the way they view, others in their country or in their locality, right? And that's, that these sort of like sticky long-term effects really do matter. Right, so I can give examples of that if there's interest. But Dr. Miller's talk got me to thinking, well, there are these sort of long-term issues in the health realm that affect trust in the medical advice we get from the CDC, or from elected officials, or from all sorts of different sources, right? And that's something that I think researchers should grapple with as well, right? There are these sort of direct sort of trust effects that are not just immediate, but they've been sort of building up over time, and those have to be at least as significant as some of the more sort of sources of typical political sort of trust deficits that scholars have spent 10 or 20 years uncovering. So I'm really eager to have this conversation, and I think it's good to be a little bit out of your comfort zone. This isn't my usual crowd, but this is where we can kind of rub shoulders with different people and learn some things. So I think this is really an important event.
Thank you. I think this is a great segue into a conversation, and maybe I'll just add a few reflections about your talk as well, Dr. Miller, and hand it over to you to maybe reflect on some of the things you've heard. One of the things that really struck me in your talk was no holds barred, and I think a comprehensive look at how people experience aspects of society that are related to their health in a much broader way than what is said about their health, right? And I think that really brought into focus for me this idea that, like if you walk into a hospital and the message on the board says, we care about you, but you can't get anyone on the phone, you can't get an appointment, you go to an appointment, you're not treated with respect, that message that says we care about you, even if it's crafted by the perfect marketing techniques, is going to sound flat at best and possibly hypocritical. And so I think bringing the wider experience into the moment is really helping us contextualize why people don't respond to the things we quote unquote say in the way that we expect. So I think that was a real point of clarity for me. But I think we do have some, I think, questions that I want to pose to all of you, but maybe give you a chance to respond to some of the things you've heard so far.
Yeah, very thought-provoking comments. In terms of trust, for so long we thought about what to say, how to perfectly frame it, when I think what matters more is who's saying it, and not what the message is, but what matters to the patient. So for example, with vaccines, I have a patient who's declined a lot of vaccines, but they take care of their granddaughter, really, really care about their granddaughter, and they were receptive to doing the RSV vaccine because that affects the elderly and the infants, and that was one thing that they could do to protect that infant. I also realized that in terms of trust, democratizing the relationship is really key. And during the pandemic, I failed over and over again to connect with patients. And then there was one thing that worked better. And that was that at the beginning of a conversation, I would say to the patient, I just knew that anytime I brought up vaccines, patients were immediately on the defensive. And so I would immediately say, it is a deeply personal choice about what you inject into your body. And I want you to know that whatever you decide about vaccines, I honor you and I respect your decision. And it's amazing. So many patients of so many different ages and demographics, you would just see their shoulders go down. And then there was actually an opportunity to have this democratized dialogue of, after that, I would say, do you have any thoughts or do you have any questions? And then I would ask permission, can I share some information for you to chew on and decide what you want to do? But they already knew that it was okay. They weren't letting me down. I wish I had learned that earlier.
So I think maybe to start with, I'm going to sort of make a proposition and see how maybe each of you would react to it. Mark, your story about the discussion that you had with the patient while they were having a heart attack, I think is a very interesting and telling sort of counterpoint about the nature of choice, right? I think we've talked a lot about autonomy, about choice, and about information, but it is also true that the kinds of choices available to people at different times and different moments in their lives is not the same. And that choice may, and there are some critics who have honed in on this, also act as a burden rather than something that frees people, depending on what the choices are and when. So Anne-Marie Moll, who's a Dutch philosopher, has compared what she calls the logic of choice versus the logic of care in healthcare, and how choice involves work. Carl May is an implementation researcher. He's written about the burden of treatment, which is that physicians and healthcare say you should do this and this and this and this, and that is a form of work on the part of patients, and therefore that caring healthcare is also about acknowledging the kind of work that patients do. But on the other hand, we I think all agree with the points you made so well, that gatekeeping information and choices can't be the answer either. That may have been how things were done in the past. It's not going to fly now. So what kinds of balances and principles might we think of? You might also disagree with the premise of the question, but let me maybe start with Mark again, and then go around. Yeah.
Sure. I mean, this concept of trust varying over time, David and I and others did a scoping review, and there's very little longitudinal understanding of how our trust, like think about your own sense of self, of how you've trusted public health or healthcare or other institutions throughout your life, and like, wow, there can be quite a bit of variability. That's not really well articulated. I think there's a lot of time of trust building in clinic, for example. That's the interstitial space of where you're hearing about the spouse who's ill and the caregiver burden that they might have, or the grandchild who's playing on the baseball team, and it has not things directly related to their LDL cholesterol or their systolic blood pressure. But I know that that's the important thing that we're doing, because we're setting up the visits that could be 3 years down the line, and now we're in a moment where we got to make a decision. So the logic of care concept of how do we allow that space to be present while not, there's just not enough doctors. So, if we are trying to prepare for the future of aging, population growth that's occurring, and we've got declining trust, but we're booked like at Barnes and WashU in a way that we need more. And this is happening like in a resource-rich place. So some of the work that we're doing internationally is trying to think of like, well, in places where they're doing more with less, that's probably going to be applicable here. So one example would be community health extension workers in Nigeria to deliver maternal cardiovascular health care. This is called ENHANCE with DKOG and the University of Abuja. And it's modeled after work that's developed here in St. Louis with a trial called ENRICH that Deborah Hare-Joshu, Rachel Tabak, Victor Davila co-lead. And trying to think about how do we merge this team-based care so that there is more touch points in the health system that allows for trust to be building slowly over time, but still allowing the specialists to probably be spending more time doing some of those higher order things. You said, why am I doing this? Oh, I am the public health system. You said, well, there might be other ways of organizing the health system so that you might be doing more of those deeper discussions on, wow, we've got to really talk about what are we going to do with this PSA that's kind of moderately elevated. That's kind of a complicated topic we got to sort through. So yeah, ideally better treatments, we'd have more cures, that'd make it a lot easier. I don't see that coming in the next 10 years. But I do challenge D&I, the field, because this is a D&I meeting, to try and think about what are the strategies that can either preserve or restore trust, and how would that be measured? Because trust is a latent construct. So it's the sort of thing that you can ask people about it, and that's kind of often the best that you can do, but that's not capturing really everything. And Pradeep Soparoy at Wayne State, who's someone we've worked with, this guy's brilliant. It's really hard to observe trust behaviors. So that patient who was having a heart attack, you'd say, well, he trusted me. Maybe not. Like we could ask him and he might say that, on the back end of it. But this decision-making in the moment, there's, I think, a like Kahneman, system 1, system 2 thinking. There's a lot of like just emotional decision-making that gets made of like, I don't want the vaccine, or I don't want your statin because it's going to cause dementia. And you're like, whoa, hey. So spending time with people, talking about some of these other things, like I like doing that. I like getting to know about people's lives, but I recognize my health system doesn't really want me to do that. They'd prefer me to be figuring out how to like titrate the meds more.
Yeah, please.
Piggyback on that. So choice can be done really well and it can be done really poorly. Here's an example of choice being done really poorly. When my husband and I are trying to figure out what health insurance plan to pick, and it is impossible to compare them, that is not empowering. When the choices are smaller and designed to honor the autonomy of the person making the choice, that's when it's empowering, effective, and building trust. Then I have another paradigm that I've seen trust in my office. I think our healthcare system is very traumatizing, and we're really stressed, and the stages of grief keep raising their ugly head over and over again. Denial, anger, bargaining, depression, and acceptance. And this one came to light in my clinic. I had a gentleman, and In terms of choice, I was trying to use my motivational interviewing skills, which are like, oh my gosh, we should all spend 100 hours learning how to do that. But I was trying, I was failing, and I asked this gentleman, I said, how likely are you to get a COVID vaccine from a scale from 1 to 10? And he's like, -11. And I was like, okay. And then we kind of went back and forth, and he's like, but I'll give you a flu shot. I'll take a flu shot, but don't you touch me with that COVID vaccine. It was a bargaining. So I think in the grief and stress of dealing with our healthcare scenario, unfortunately, some of our choices looking like bargaining.
David?
Yeah, so one thing that strikes me about a lot of these conversations, and I reflected on, we had a little discussion, to think about the panel beforehand, and some of these moments where, you're dealing with a patient or someone you know well, and you have an opportunity to communicate with them, to empathize with them. I feel like those are important moments, right? They have some amount of trust for their primary care doctor, people they know well, and sort of making the most of those moments. There are a lot of sort of social ties that we have. People trust a lot of other people, right? They trust local institutions. Their national politics and these things are highly polarized. Trust is in bad shape on a lot of dimensions. But I think getting people's attention and empathizing with them, and then relaying information in a way that sort of, I don't want to say makes concessions, but understands what their position is. That's really important. So this example connects in my mind. Just this point of networks of trust and sort of making the most of them. Because I agree with Mark that we don't know a lot about how this varies. So I just implemented this trust game sort of lab in the field experiment. I was actually just talking with someone about it in Mali before the panel. So we're basically asking respondents to play this game where, they can, trust in another partner they've been paired with, and there are like real sort of monetary consequences to trusting and then being like trustworthy, right? So you get an endowment of money essentially, and then you can share it with someone else, and it'll multiply by 4, and then that person can choose to sort of split the proceeds with you, right? So you have to trust the person that you're sending it to, and then the receiver has to be trustworthy. So we did a lot of manipulations to this setup, and what we found were that people that sort of share a voluntary association, meaning they're in some neighborhood group, or maybe it's tied to a religious organization. There are a lot of other examples of this. They actually have this sort of very strong belief in reciprocity, and it's even stronger than things like co-ethnicity, which are supposed to sort of drive everything in Malian politics, and we didn't find that, right? And so what my point here is that there's this reservoir of trust that I think we can leverage and build on, but we need to get people's attention. Maybe that's through social media, right? That's half of the battle, and then actually communicate something in a compelling way that resonates with people and sort of makes sense to them given their experience. And it's very hard, but I think we do have some reason to be hopeful, right? We have Mark here who's saving people's lives. Patients trust him, and we have a lot of actors that are in the health system and in local politics also that we just need to make the most of those opportunities and build out from that.
All right, one quick last round for the panel, and then we're going to open it up. So we have been talking about trust and interpersonal things. I'm going to take this to a little bit of a macro level. Heidi, you mentioned that almost everybody sort of across the aisle cares about health. And I've heard, Dean Galea make this point as well. So how would you explain that while recognizing the fact that we underfund perhaps public health in general, and maybe in Missouri particularly so, And you pointed out that we rank relatively low in terms of per capita funding for health. So why is that disconnect? And then what can we do to close that gap?
That's a really big question. And we need the whole state to help with that. So let me start with the first part. You said everybody cares about health. So even on the most polarizing issues, I was in the Capitol trying to work with a legislator to pass a bill to create more physicians, because we're 2,100 short in the state of Missouri. We were trying to grow more GME slots, and there was, at the exact same time, there was a vote about transgender care on the floor. And the legislator came back very emotional. I think it's important for us to understand that there is emotional feelings and triggering on both sides of every single issue. Abortion, transgender care, even alpha-gal syndrome, even scope of practice. The more that we can understand that, like, well, what matters to you? Do you care about children? Okay, let's talk about that. Let's find out how we unite on that. Now, in terms of activating change and resources to address health and public health issues, I truly think that the uniting language, and we all have to speak Democrat, we all have to speak Republican, and we have to speak independent, but really health economic terms are a uniting language. If public health is done correctly, it is cost effective. And if it's not cost effective, then we're doing it wrong. And if we haven't proven that it's cost effective, then no one's going to put it on their state budget.
Mark, do you have
How do you tap into the resources that communities have that may not always be government driving this? Because I think there's a lot of assets in our great state of Missouri, my home state, that could be, brought to bear, so to speak, for more. I think in that conversation, you want to figure out, well, who could potentially be left out without some particular attention to reducing inequities that have been long-standing. And because of those, that obviously drives low trust. And so they are kind of wrapped up, sort of the structural components of this. And it's a big deal because these are kind of like wicked problems. We're not going to solve them without broader trust. So this class that Matt Gobble and I taught on trust in public health this past fall, one of the students, Leo Clayman, his whole project was on nuclear waste disposal. It's like kind of a cool, obviously requires tons of trust. And you think just yesterday, the 6 homes in Florissant by Coldwater Creek were demolished. I mean, decades after that was contaminated. So there's a long tail of all of this. And obfuscation, that was, it's okay, it's gonna be fine, maybe not. And it's a hard thing to figure out, like what Leo's trying to do on nuclear waste disposal. But we got tons of problems like that are gonna require a collectivism that, right now I don't think we're feeling it in the way that I think we'd like to be feeling it. And that's probably how to do that. I mean, that's a lot of people are thinking about that. I don't have the magic answer.
Collectivism, what do you think, David?
Yeah, so that's a really interesting and important example, right there. So you can think about trust in a bunch of different ways, right? But some of these sources of mistrust are very deeply rooted, right? And sometimes it reflects more in the moment, political dynamics, right? So vaccines get politicized. 2021, before that a little bit too, but that's we can kind of understand when that happened. But then there are these sort of long-term effects that are, I think, more difficult to grapple with, and they're harder to understand, right? Where you have populations that have been mistreated by the health system historically, mistreated by the political system in a lot of ways, and that those are memories and experiences that, don't just go away quickly, with words. It probably requires a different approach, to thinking about, how to, deal with these trust deficits, if not, think about repairing them, which is very, very hard, right? So I guess my point is sort of trying to sort of think about this discussion and make a point based on things that we've sort of thought about in our research group here, Mark, myself, Matt Gobble, and Jimin Ding in mathematics, are that you have different sources of sort of trust deficits, right? And we probably need to understand, well, what sources of a lack of trust are really tied to vaccine hesitancy, for example, right? And what policy options may or may not make sense, depending on why is trust so low in this community, whereas it isn't in this one. And these are hard problems, but I mean I think that's the point of doing research. So WashU is a great place to sort of harness research resources, and you have a bunch of smart people thinking about these problems, and I think we can start to make some real headway.
Alvin, do you mind if I make a quick addition on the trust issue? The only mistakes I've made clinically in my career is when I assume that the patient trusted me enough to tell me the truth. I'm really proud it'll happen, but I haven't missed an important diagnosis, but I missed the crack cocaine use and treated all the repercussions of it because the patient didn't trust me enough to tell me the truth. I shared this once about 10 years ago with the WashU med students, their first week of school, during their first WUMP plunge orientation. And I was talking about trust. Like, what we do is meaningless if our patients don't trust us, and you have to earn it. And the student raised his hand and he said, Dr. Miller, how do you earn trust? I was like, okay, you're gonna spend a decade or more trying to learn that. But the most important thing to earn trust is to never assume that you have it. And so I think we're all tasked to keep that in mind in order to even begin to start earning it.
Brilliant. So I think we're going to open it up and have some questions. We can start in the back there with Mary, please.
Is it on? Thank you so much. This has been such a great morning because I'm filled with thoughts. So I'm just going to ask one question, and it's about who the patient is or who our message recipient is, because we've been talking a lot about the patient in the context of a clinical setting, which is hard to build trust, but it's in many ways easier than when we're dealing with the public and public health messaging. And I think that's where some of the vaccine messaging has gone awry, because we can talk to an individual and ask what matters to you and shift our message in that conversation. But the public and public health messaging is really about what's benefiting this broad population. And sometimes that conflicts with what the individual might want. So I wonder if the panel has thoughts on how we craft a better message to build trust to the whole population and do this elusive shared decision-making, which is now being described for vaccine messaging, with the public as opposed to with the individual.
I think the question of what matters to you can be expanded into a population health level, because different things matter to different folks, but there are things that may surprise academics or those of us who are in the working on it on a professional level. It's also really interesting to follow what Dr. Steier said earlier of what are the social media posts that they're following? And why are they following those? To follow those footsteps. Any other thoughts?
I think trying to remember what has worked potentially in the past. So a lot of public health regulation locally driven around tobacco, indoor tobacco bans, for example, would be that's a singular type of exposure, but there's a lot of lessons to be learned from that in terms of how long it took, first of all, what the messages were that it was harming people, workers in bars and restaurants, for example. So we collected data using PM2.5 monitors in Uganda, and those were the only indoor air quality data that were used because British American Tobacco had sued the Ugandan government for, violating their rights for business. But the ban was upheld because we, as scientists, collected data that observed that there was harmful air quality for the workers. It was not that you can't smoke, but you just can't be harming other people. And so trying to figure out, are there instances where that may be the case? And that might be in terms of communication. So when we think about trust deficits or low trust, I would contend that that's different than distrust, where you're trying to actually harm, like someone who actually shot at the CDC building. That's someone who's trying to dismantle a public health agency. And the strategies to mitigate those, I think, are quite different.
Great.
Yeah, thank you for the fascinating presentation. Dr. Miller, I found it interesting that you mentioned cost effectiveness in a conversation about trust and communication, but I think it's very important. Would you help bridge that gap a little bit? Because I know there's a conversation about impact as well, which comes with cost effectiveness. But in your position as a policymaker and also a physician, how do we bridge that gap for the audience and researchers like me who want to also work in this field?
Great question. We can use the brain trust in the room to figure that out. I haven't figured it out entirely, but I think it's important to... The budget right now in the state of Missouri is so tight that you can understand the perspective of budget committee members and policymakers of like, don't give me one more good idea that we can't afford. If you have a good idea that's cost effective and may unite silos and we can synergistically fix things and we can work upstream, I want to hear that. But literally, it's just bare bones. The budget is so limited. I do not think that we can talk about good ideas unless we can afford them. And that's reading the room. I don't think I answered your question, but let's brainstorm afterward. You got anything better, guys?
I mean, do you think the political goal is to attract more residents to the state of Missouri to increase revenue is that the kind of ultimately what the strategy might be? As the governors just talked about eliminating income tax and looking at states like Tennessee and Texas and saying, wow, maybe Missouri could be a place where it's more attractive for people to live because of a rosier financial climate based upon income tax. And therefore a rising tide will lift all boats, and therefore we'll be able to do all this later. That's what I'm reading on this, but I mean, you're in the middle of this.
But what I like about what you said the most is the engagement with Republicans as well as Democrats. And I think a lot of institutions traditionally have prided themselves on diversity when they have not had diversity of political thought. And so part of answering that question is engaging with our Republican leaders and our Democratic leaders in order to figure out what matters to them. If it's business, if it's growing the population, there is a way to protect the economic interest of the state while enhancing health. And in fact, you could argue you can't enhance the economic state of the state without enhancing health.
All right, great. You know what? I'm going to take a couple of questions from the Zoom, the online folks, if that's okay. And then I think we probably are tight on time. So I'm going to exhort our panelists to give quick answers to these, but we'll take one from the Zoom and then, okay. So this one, if you had to name one concrete action public health leaders can take right now to confront the current anti-public health sentiment, what would it be? Any takers?
I'll go from the academic public health community that we need to be able to understand strategies that can preserve or restore trust. I think that that's something that the D&I community could focus a lot more on. Like we've got problems with measurement. We don't have a lot of understanding of variance over time, just how that varies, but also strategies. That would be useful because there's not a lot of data out there.
Great.
Yeah, I think that there's this viewpoint, and this touches on some of the things that Heidi talked about in her presentation as well, that, in giving advice on vaccines or recommendations where, people feel like they're being talked down to. Things are being explained to them as if they don't, really understand the science, or they don't understand why this is true, but it just is, right? So I think that's a real problem. I'm not the kind of doctor that these two are, right? But I had a bunch of conversations about vaccines with, people that were in my house, fixing my boiler and this sort of thing over the years. And that's something that really comes out strongly, in a lot of examples of, people I've spoken to that just had no interest in getting COVID vaccines. They were very against them. There was this description of, well, this is how this was explained to us. They're just jamming this down our throat, telling us it's mandatory, we have to do it, and it's not clear why. So I think that's a barrier that needs to be worked on. Just explaining to people on their own terms a bit more effectively.
Heidi.
I think we need to clarify what the definition of public health is. Because if the thought is like, well, what do we do about this distrust in public health? Well, what are you talking about? Because it's not isolated into little things. It is a big ecosystem. So when you're saving a patient's life and he's about to code, and he gets cath, survives, when you tell him to quit smoking, that is the single most important public health intervention for him, his family. So where do you draw the line? I mean, tobacco cessation is a bread and butter public health endeavor, but we can't do it without our partners. So first, to answer the question, we have to define what public health is. And then I would say share the power, own the arrogance that we have carried, and shed it.
Great. I think we can take one last question. I'm going to offer this gentleman here, and then there are questions online which I don't think we'll get to, but if it's okay, we can send them to each of you, and maybe we can do a little bit of a close the loop that way. But please go ahead.
Thank you so much for the panel discussion, and Dr. Miller, thank you so much for your presentation. I will ask you later for advice of talking to sons who think they know everything, but I actually am kind of curious on that one, that the generative AIs have gotten really good, and those of us who view us of having our positions because of our expertise are starting to become humbled at how well information can come out. And you talked so much about you don't have the time, so they turn to their phone. You don't have the time, so they do this other thing. What are the prospects for you partnering as physicians, mostly to you, Dr. Miller and Dr. Huffman, about how can AI be your partner for a better patient experience?
I was rolling my eyes at AI taking over the primary care doctor entirely, and I was like, okay, you want to meet my patients? You want to try to do that? There's actually a very funny Reddit about doctors are like, AI will be able to take over my job when, and all the doctors filled in like how to deal with AMA and all these different things. So, however, we need tools to be helpful. You saw that picture of myself like looking at the computer instead of looking at my patient, spending forever finishing my notes. So I think the first entry point probably is ambient AI. I think many of us, including public health professionals, can use that as well for recording meetings. We don't need to be our own secretaries. Our health center can't afford ambient AI, but every provider I've talked to loves it. It's time saving so that they can actually have more contact. Likewise, a lot of providers are using openevidence.com. All AI is potentially faulty, needs to be double checked, but wow, that is a powerful initial tool. And even in the middle of a Saturday when I'm charting and I've got a patient that I'm literally putting 13 orders in relation to what their specialty visit encounter said and the labs that I drew, and then I'm just about to sign the note, just in the same way that I can click the corner of Chrome, and I can ask a question about the web page, it would be really awesome just to click and be like, am I missing anything? So to use it as a tool, not as a replacement, and part of the reason why it can't be a replacement is that we really need to, we are human beings, we are mammals, we need to interact with each other. AI is an awesome tool to help with that, but won't replace it entirely. Any other thoughts?
Yeah, human plus AI is better than either alone in this instance.
Yeah, good.
So we got to watch out what we could lose in the process, like taking a history someone's telling you their story. They're not a bad historian, you're a bad doctor if you can't kind of get that piece, that critical piece of information. Also think about the idea of like who people trust. It's people like them, for example, that quote that was earlier. And our experiences allows us to be able to ask the right question. I can't tell the number of patients who've like freaked out with a lab value that is mildly off that we don't even look at in the complete blood count, for example. It's always off. Don't worry about it. No big deal. So we can help the patients ask better questions for themselves. But these tools are pretty remarkable. Open evidence being an example of, it's going to help us probably make more accurate diagnoses. I bet there's more misdiagnoses running out there than we realize. And then we'll be able to hopefully match better treatments for those patients. I think it's going to be a little rocky, just my own sense, because the docs, like, we only have a 10% uptake in the first month or so of ambient AI at WashU, because doctors, including myself, like, it's new. I know how to do it well. I've been doing it well for a long time. I know it's the future, but just the activation and energy. So we're all going to go through this transition period for the next handful of years at least. But human plus AI will probably be better than either alone.
All right, I think we are at time. Please, a round of applause for the speakers. I'm gonna send Byron a WhatsApp message to tell him that this session is over.
So first of all, thank you so much to our panelists, to our speakers, and thank you to all of you for your engagement this morning. So another round of applause for them, please. I realize that I'm standing between you and lunch, so I will be brief, but really exciting today to see the numerous connections to implementation science and to our directions moving forward. I think the theme of the morning for me was humility and all of the ways in which we could better exercise humility in our work. I think we heard numerous points that I think are both challenges to and increasingly directions in implementation science. For instance, embracing practice-based evidence, prioritizing the relational aspects of the work, leveraging participatory approaches to research and practice through community-based participatory research or other community-engaged work within the field. This need to draw upon multiple disciplines. So already great to have political science, communication science, a variety of disciplines represented in the room. And I think in implementation science, we often beg, borrow, and steal from multiple places, but don't do so deeply enough. And so I think really excited about the prospects of this network doing that more intentionally as we move forward. So thank you all for your engagement in that. We also heard about moving away from passive one-size-fits-all approaches. I've not heard about post and pray, but I always preach about train and pray and other approaches to implementation that are often ineffective or necessary but not sufficient to move the needle in implementation science. And so exciting to hear about all the ways in which our directions aren't one-size-fits-all, but are increasingly tailored, contextualized for different individuals, systems, organizations, and so on, and even the move towards more adaptive approaches in implementation science. So really excited about what is to come for this network. These are exactly the kind of conversations that we hope to spur throughout this network, and so we invite you to engage with us moving forward, and really excited to have you all here and a part of this. So thank you again for your participation today.